Akash.
Can Pragyan Dhal identify themselves, please?
Yeah, hi. I've just logged in, but I don't.
Yeah, Pragya, I can see you. Yours is fine. There is I can see another person logged in called Pragyan Dhal. So I was a little confused about it.
Shefali, am I signed in as Pragyan Acharya or something else?
You are signed in as Dr. Pragyan Acharya at gmail.com. Complete email ID showing. If you can just put in Pragyan Acharya, Dr. Pragyan Acharya.
Okay, I'm trying to do that. Hang on.
Yeah.
Yes, sir, your screen is visible. Just move and forward your slide. Yeah, it's fine. Yeah, it's fine. Yes, sir, it's fine. Okay.
Dr. Dhal, can you please identify your full name? As your audio is not connected.
Shefali?
Sir, good evening.
Good evening.
Yeah, doctor.
Have all the speakers for the plenary session joined?
No, just now I just have Pragya, Dr. Pragya and Dr. Piyush.
And judges?
None of them have come in as yet.
That spreadsheet has been sent to them?
Martin,
Yes, sir.
Okay. And what about Hall B?
I can hear you.
All be also sent.
Is Dr. Puri there yet or not?
Dr. Puri is in hall?
Can you change your
Ek minute se check kar
name on your screen if your email ID showing?
नहीं सर, अभी नहीं है.
And अभी platform live नहीं हो रहा,
Platform is live.
but मुझे तो Hall A में हम नजर नहीं आ रहे हैं.
Please, sir, you can try.
नहीं, ट्रांसमिशन नहीं शुरू किया सर अभी.
Okay, okay.
हाँ जी. Broadcast once we go live, then we'll announce. But वैसे
You
live
want
है
to share
platform.
the screen?
Right, right.
Want to check your presentation? Yeah, you can share your screen and check.
Good evening, Dr. Shalimar.
Perfect.
Dr. Pragya, can you share your screen once? कल problem हो रही थी ना, तो आज ठीक है. Let's see.
Yeah, sure. Let me try.
Yeah.
It says I can't screen share while another participant is sharing. Can I-
After screen share.
Yeah, now
Yes.
I can hang
Yeah.
on.
Yeah.
Can you see my screen?
Yes. Yeah. Fine.
Is it transitioning?
Yes, it is.
Okay.
Thank you, my dear. Now you can undo. Yeah.
Yeah.
Thanks.
Good evening, ma'am.
Good evening.
Ma'am, am I audible properly?
Yes, I can hear you.
I'm sharing my screen. Just
Okay. आफ्ताब स्क्रीन शेयर बंद करिए अपना.
can you check the bandwidth?
Okay, you share the screen. We can't see the screen as of now.
1 minute.
Yeah, I can see. Do a slide share, please. After bandwidth check करना please.
Okay.
Okay. Okay.
Madam,
Yes, it's okay. It's okay, Dr. Mahapatra.
bandwidth is okay?
Yes.
It's okay. Thank you, ma'am.
Thanks so much.
एक घंटे का सीरीज
शिफाली बैनर थोड़ा ब्लर्ड आ रहा है.
So we are live now. After, can you just check?
The banner is a little blurred. Now this is better. This is fine. This is fine. This is fine.
Okay, sir.
Good evening, Dr. Agarwal.
Hi, Marshall. How are you?
Sir, the flow will be like this. I'll hand it over to you, and each judge can invite one of the speakers. And
So I need to know the sequence of the 6 judges if I have to hand over to the next one, right?
so that is there with you in the program, sir.
So I have to open that, right?
Same sequence has to be followed. So you can, I mean, when I hand it over to you, you can say all this, that each judge is to invite one speaker. The question answer is for 3 minutes each.
Yeah, I have to hand over only to Dhiman. Dhiman can hand over to the next one.
Pardon?
I need to hand over only to Dhiman. After that, it is his job.
Yes, and then Dr. Singh and Dr. Saraswat.
वो तो relay race होती है ना, उसके अंदर sequence fixed होता है.
हाँ, वही फिक्स सीक्वेंस है सर, बट रेस फिक्स नहीं है.
Race का sequence fixed है.
जी. So
Result fixed नहीं है.
So in your mails, you would have received the spreadsheet. So scores are to be entered there and sent back to Dr. Rakesh Agarwal.
तूने भेज दी वो score sheet? Good.
हाँ जी सर.
तुम बहुत ही मेहनत कर रहे हो यार.
नहीं सर, ये शिफाली कर रही है.
अच्छा.
मायशा वाले कर रहे हैं सर. मैं तो बस इंस्ट्रक्शन दे देता हूँ.
जो भी है वो भी जरूरी है. शेफाली आगे से ना ये स्प्रेडशीट आपके पास आपका आइडिया से आनी चाहिए.
सर ये आईडी मेरा ही है, inasl@maishaservices.com.
हाँ मैंने बना के भेजी है, अभी वो वाली नहीं भेजी, आपने अपनी भी भेजी है।
हाँ जी, नहीं, next time I should follow your one, sir.
नहीं मेरे को कोई फर्क नहीं पड़ता, आपकी वाली मेरे पास नहीं आई अभी तक।
Kaushal, the spreadsheet that has come cannot be opened because there's some problem.
I haven't even received it yet.
I received it, but one cannot open it.
It's not opening?
It's not opening, and I'll tell you what it says. It says when I open it, says the file format or extension is not valid. The file format is XLSX.
I'll just have a check, sir.
ये कुछ गड़बड़ कर दिया तुमने शेफाली फाइल को।
Sir, it may not be opening on his system because it is not compatible with that Excel format. That's it.
वापस मेरे पे भी नहीं खुल रही ना। ये वही वाली है जो मैंने भेजी है, तो मैं भेज देता हूँ सबको।
आप भेज दीजिए, मैं इसको फिर रीफॉर्मेट करके भेजती हूँ दूसरे पे।
नहीं मैं जोड़ रहा हूँ, मैं उसको रिप्लाई टू ऑल कर रहा हूँ। प्लीज यूज दिस फाइल। भेज दिया मैंने। Just see Rashad, does this open?
Yeah, I'll check right now. Dr. Rakesh, I have received it in the correct format. Thank you.
Thank you. Dr. Kaushal?
Sir.
The audience questions will appear in the chat box, is it?
Yes, sir. And the judges can be strict with the timing if they want to.
They have to be. I think one person will have to do the timekeeping.
So there'll be a timer here. I mean, when you're asking questions, that is the time there is a chance of going beyond time also.
So I become a super chair at the time. If you want me to do that. Ashwin, you're still sitting in your office?
Yeah, I'm still sitting in my office, yes. Because Saturday is a working day for us.
No, it's working day for us also, but supposedly till half time, but I came home at 3:30. So it's better to carry work home rather than sit there.
Because I have to come back. I mean, I have a session from 8:15 to 9 again. So I thought it's better to do it in the privacy of your department.
You are almost the family member at home that they don't give you privacy. Okay, I think we get formal.
So Dr. Rakesh, ever since you took over, we haven't really met in person. Took over Pondicherry.
We have moved closer to each other, no? Neither the church, the farther from God. I'm closer to the God, but I'm still farther from you.
Hello.
Welcome, sir.
Hi, Dr. Singh.
Hi.
Welcome, sir.
Rakesh,
Sir, you are on the dais, so you can't make public remarks.
Rakesh, is there any order who's going to invite whom, something like that?
Sir, I will invite the first person. Dr. Bhiman will invite the second person. Dr. S.P. Singh, that is you, will invite the third person. Dr. Saraswat, the fourth. Dr. Abhijit Chaudhary, the fifth. And Dr. Harshad Devar-Bhavi, the sixth. In the Inasl tradition of 6 speakers, 6 chairpersons. Abhi, the only problem is that if someday Ravan comes to present, then we'll have 10 chairpersons.
So, Pragya Piyush Shalimar. ठीक है,
Sir,
तो मैं शालीमार को इनवाइट करूंगा.
अब आपको पेयर किया हुआ है शालीमार के साथ.
ठीक है, fine, that's fine. शालीमार यानी वो अमित गोयल वाला है ना.
Dr. Dhiman by mistake has gone to hall B. He'll be joining soon.
वो डायरेक्टर बनने के बाद में थोड़ा एब्सेंट माइंडेड हो गए, अनलाइक राकेश.
आपने एक सेंटेंस बोल के फर्स्ट यू हिट 2 birds with 1 stone, then you said थोड़ा पीछे हो जाओ. Anyway.
So Shifali, please let us know when we'll go live. It's about 2 minutes left.
Yes, sir, I'll announce.
Dr. Singh, you would have got an Excel sheet. Please have a look at it.
Yeah, I got it. Yes, sir. Hi, Harshad, how are you?
Notice it fine, thank you. How about you?
Yeah, just returned from Pune.
Pune just came from Pune.
Yeah.
All well?
Yeah, in Cuttack, I was unable to get COVID. So I thought, let me go and make a trip to Pune if I can get COVID there. Let us see.
Vaccinated, not vaccinated?
Vaccinated.
Everyone, we are go live
Why
in
did you
30
get
seconds.
vaccinated if you wanted COVID?
Everyone, please mute. We are go live in 30 seconds. We are live now.
Okay. Good evening, everyone. So we welcome you again on this day 2 of the 22nd annual conference of Indian National Association for Study of the Liver. We had almost 3.5 hours of back-to-back very interesting sessions yesterday, and now we are here for more. And we are starting with the plenary session, wherein 6 abstracts which were selected out of about 27 papers which were submitted, and the top 6 were selected by the same 6 judges who will be judging these papers now. I agree, there was some deviation from the protocol. Normally for young investigator session and plenary session, we usually invite or request the researchers to submit full papers. But this time, because of the uncertainties of COVID, we only asked them to submit an abstract. So maybe we'll be able to do it differently next year. So from here, I'll hand it over to Dr. Rakesh Agarwal to start the session and invite the first speaker. Dr. Rakesh, please.
Thank you, Dr. Kaushal. Good evening, everyone. On behalf of myself and Professor R.K. Dhiman, Professor S.P. Singh, Professor Vivek Saraswat, Abhijit Chaudhary, and Harshad Devar-Bhavi, I welcome you to this session for plenary session where we have 6 papers to be presented. For each paper, we have 12 minutes and 3 minutes are for questions at the end. I request the audience to place their questions in the chat box and we'll try to cover as much as possible. And we intend to stick to time. Let's start with the first paper. And the first paper is by Dr. Pragyan Acharya. And she is going to speak on her study upregulation of ELANE, MPO, CD177 genes in ACLF-derived granulocytes. Dr. Pragyan Acharya, please.
Good evening, everyone. First of all, I'd like to thank Inasl for giving me this opportunity to speak about our work on inflammation in acute on chronic liver failure, or ACLF. As you all know, ACLF results from acute injury over an underlying chronic liver disease and is characterized by a massive tissue damage. Whenever such massive tissue damage occurs in the human body, it leads to the release of damage-associated molecular patterns, or DAMPs, and when accompanied with infection, it leads to the release of pathogen-associated molecular patterns, or PAMPs. And DAMPs and PAMPs together activate the innate immune response pathway in the human body. Now, this activation of the innate immune response in response to tissue injury or infection is a normal event. But in ACLF, it has been found that innate immune activation is unchecked and dysfunctional at the same time, causing multiple organ failure and mortality. In recent studies, the neutrophil to lymphocyte ratio, neutrophil is an important component of the innate immune response in the human body, and the neutrophil to lymphocyte ratio has been emerging as an important prognostic marker for ACLF mortality in many populations, suggesting that there is an expansion of the neutrophil population during ACLF. Although it is now established that neutrophils are expanded, the molecular phenotype and molecular mechanisms in ACLF neutrophils are still poorly characterized. Therefore, the objectives of our study were, number one, to understand the molecular phenotype of ACLF neutrophils. Towards this, we used transcriptomics analysis to understand the gene expression profiles of ACLF-derived neutrophils. And number two, to investigate whether these gene expression patterns associated with any patient-centric outcomes, such as mortality. Towards this, we recruited participants from 3 study groups, that is ACLF, compensated chronic liver disease patients, and healthy controls, and enriched polymorphonuclear cells from their whole blood, which consist of a high number of neutrophils. And these were characterized using cell surface markers such as CD14, CD16, and CD66B. Enriched neutrophils were then subjected to microarray analysis, and then we did an analysis for differentially expressed genes that were characteristic of each of the study populations, and further validated them by quantitative real-time PCR in an independent cohort of study participants in ACLF, CLD, and healthy controls. This dot plot shows you the CD66B staining of ACLF neutrophils and CLD neutrophils, and you can see that most of the ACLF and CLD neutrophils express the surface activation marker CD66B, suggesting that these neutrophils are already in an activated state. Next, the differential gene expression analysis in the across the 2 comparators, ACLF versus CLD and ACLF versus healthy controls, gave us many genes. And the red arrows indicate some of the genes that we decided to follow up in our study. When all these differentially expressed genes were analyzed for overrepresentation of specific pathways, the pathway that came up was neutrophil degranulation pathway, which was common to ACLF's comparison with both the control groups. Now, what is neutrophil degranulation? If you recall, neutrophil belongs to a group of innate immune cells known as granulocytes because of the presence of these granules in their cytoplasm. These are electron microscopy images of neutrophils. And these granules can be of many different types, primary, secondary, tertiary. And when these granules are deployed outside the cell, they lead to all the extracellular activities of neutrophils, such as bactericidal activity or cytotoxicity, netosis, and lymphocyte regulation. Our data suggested that in ACLF neutrophils, there's an increased accumulation of granule components. These granules have the classical neutrophil enzymes, ELANE and MPO, elastase and myeloperoxidase. I'm sure you have heard about them before. And in addition, they have many other proteins and with enzymatic activity and matrix degradation activity as well. Therefore, because neutrophil degranulation was a major pathway, we chose 5 genes which are actually implicated in neutrophil degranulation pathway from the differentially expressed gene list based on how many fold upregulation they showed in ACLF. These were ELANE, MPO, CD177, OLFM4, and OLA. These are names of genes which are related to degranulation. Quantitative real-time PCR-based estimation of these genes revealed that among the 5 genes, ELANE, MPO, and CD177 were the most consistently and highly upregulated in ACLF as compared to CLD. Therefore, we decided to characterize these further. Until now, what I showed you were gene expression data. Next, we asked whether the proteins which are translated from these genes are also overrepresented in ACLF because the functional aspects are carried out by proteins. When we carried out this Western blot analysis to look at the protein expression of MPO, we found that in ACLF, there was a higher level of MPO protein as compared to CLD for the same amount of total protein in each. What this suggested was that in neutrophil, these granule components consisting of ELANE and MPO tended to accumulate in ACLF as compared to CLD. Now, MPO is an enzyme known as myeloperoxidase. MPO is the short form of myeloperoxidase, and it's known to be involved in generation of reactive oxygen species, which is critical for the oxidative burst in neutrophils. What this data suggests is that ACLF neutrophils have a higher tendency or higher capacity to generate reactive oxygen species even at resting stage. Next, we decided to look at CD177, the third gene which was elevated in ACLF. Now, CD177 is, as the name suggests, it's a cluster of differentiation protein and it's expressed on neutrophil cell surfaces. CD177 interacts with beta integrins and another protein called proteinase 3 to form a large complex on neutrophil cell surface. The function of this large complex has been established to be interaction with the cell adhesion molecule PCAM1, which has been shown to be expressed on endothelial cells. So the purpose of CD177, which has been established so far, is interaction with endothelial cell surface molecules, and it's believed to be important. This interaction is believed to be important in neutrophil transmigration from circulation to tissue. When we looked at CD177 expression through flow cytometric analysis, in this panel, in the last panel, you can see in Q2, quadrant 2, the CD177 positive population. What we found is that in ACLF neutrophils, the expression of CD177 was much higher as compared to CLD or healthy control. In fact, in ACLF neutrophils, we found that on an average, 80% of the neutrophils express CD177, whereas in CLD, it's about 50%. That's almost a 30% increase, which is huge. What does this mean? Now, CD177 is a neutrophil cell surface marker and defines a subpopulation of neutrophils. There has been a lot of work which has been recently done in neutrophil subpopulations. Just like in macrophages or T cells, you have various kinds of subpopulations. You must be aware of M1 and M2 macrophages as well. Similarly, in neutrophils, CD177, as well as another gene which we initially selected, OLFM4, they mark neutrophil subpopulations. It has been shown that through facts-based sorting, that CD177 positive neutrophils tend to have a higher expression of ELANE and MPO genes, tend to produce more ROS, less pro-inflammatory cytokines, and more IL-22 and TGF-beta. Whereas CD177 negative neutrophils express lower levels of ELANE and MPO, higher levels of pro-inflammatory cytokines, and lower levels of IL-22 and TGF-beta. So it's almost as if in ACLF, this entire subpopulation of CD177 positive neutrophils has expanded, which also express high levels of ELANE and MPO. and this may be linked to pathogenesis of ACLF. Recent studies with COVID-19 infections also show that CD1 neutrophil specific CD177 is highly elevated in severe COVID patients having multiple organ dysfunction and is also correlated with COVID mortality, indicating that this CD177 positive population may have a pathogenic role in not only ACLF, but in other diseases as well. And it is probably performing some sort of a pathogenic function, maybe cytotoxicity through ELANE and MPO in tissue sites. So we further analyzed gene expression data by stratifying ELANE, MPO, and CD177 expression levels based on survivors and non-survivors in ACLF. So we did this stratification based on 28-day mortality. And we found that the expression of ELANE, MPO, and CD177 were higher in ACLF non-survivors as compared to survivors. Overall, to summarize our findings, we have found that in ACLF, a neutrophil subpopulation characterized by CD177 expression and expressing high levels of ELANE and MPO is highly expanded in ACLF as compared to CLD, and that this may provide a therapeutic opportunity for us in ACLF. For instance, in the future, once a direct pathogenic link is established, we can design monoclonal antibodies to deplete this pathogenic subpopulation and allowing us to control multiple organ dysfunction or mortality in ACLF patients. In addition, CD177, ELANE, and MPO can form a 3-gene signature that may help us in evaluating ACLF patients who are at a greater risk for 28-day mortality. With that, I come to the conclusion of my talk. And I would like to acknowledge my team members, particularly Rohini, who has contributed a lot of the experimental data, and other members of my lab. And I would like to acknowledge the help of my collaborators, Dr. Shalimar, Dr. Prasenjit, and Dr. Venkatesh. And thank you for your attention.
Thanks again for finishing in time. I have a few questions. Did you do the polymorphonuclear cell count in these patients on the same day on which specimen was collected?
Yes, we have done that, and we find an increased neutrophil to lymphocyte ratio of these patients as well.
So CD16, as far as I recall, is present not only on polymorphonuclear cells, but also on NK cells and other cells.
Yes.
So basically, this expression that you are measuring, because your control must be something like actin. So basically, it is showing you the proportion of polymorphonuclear cells in the total CD16 positive
yes,
cells.
Sir. Yes, sir. So actually, the transcript, you are right. The transcriptome that we have measured is a transcriptome for polymorphonuclear cells. And
but your total cells that you took were CD16 positive, which included
yes. So the total, so then
cells, macrophages, monocytes. So basically, what you are seeing as expression is proportion of polymorphonuclear cells in the total cells, right?
So what we did was that we took the whole blood for looking at gene expression. What we did was we took the whole blood, enriched the polymorphonuclear cells, thereby eliminating the PBM.
That's exactly my point, Dr. Acharya, that you did not enrich for polymorphonuclear cells. You enriched for polymorphonuclear cells, macrophages, monocytes, as well as NK cells.
So we did
in a disease where there is acute inflammation, the proportion of PMS will be higher and you would get a higher signal.
Yes, sir. That's why we did a CD14, CD16, and CD66B staining, so that the CD14 is like a pan macrophage monocyte marker. So then we gated in only on those cells which were CD16 positive but CD14 negative. In fact, in our enrichment protocol, we found that it was quite effective in eliminating the CD14 subpopulation.
Anyway, so, and also there was a huge overlap between the groups, right? So my question is, when you say that this can predict prognosis,
right,
is it any better than polymorphonuclear cell proportion?
So that's an excellent question, which I also have, and that only time will tell when we actually.
You know the polymorphonuclear cell number in these people, so you could have
Yes.
as well seen
Yes.
that whether that is doing it, because to me that is the first question that these data raise. Do I need to do so much gene expression if polymorphonuclear cell count can tell me something?
Yes, sir, you're right about that, and that is something we want to do when we have a little bit of higher, numbers in our study groups. Because to actually get a quantitative estimate of performance, we need better numbers, better sample sizes. But yes, that is something that we are planning to do as well.
Anybody else have any questions? I don't see any audience question. Are we done with time? I think I'll stop there. Thank you, Dr. Acharya. And may I request Dr. Dhiman to please invite the next speaker. Thank you. A lot of hard work. Thank you.
Dr. Dhiman?
Yes, thank you, Dr. Rakesh Agrawal. And now I will invite Dr. Piyush. I have to check just a minute. I think he can come and just start presentation without wasting any time.
Okay, sir.
Yeah.
Is my screen visible?
Yes, it is visible.
Okay. Honorable judges, I, Piyush Upadhyay, will be presenting my paper to study the incidence of relapse and natural history on stopping antiviral therapy in children with chronic hepatitis B. The natural history of chronic hepatitis B after stopping treatment has been well studied in adults. There are established guidelines given by APASL, EASL, ASLD, and WHO in this regard. The predictors of relapse have also been well studied in adults. However, there are no such studies in children and adolescents as of yet. This implicates a prolonged duration of antiviral treatment, as HBsAg seroconversion rates are low on antivirals, which increases the risk of drug resistance with increasing duration of treatment and higher adverse effects of drugs with prolonged duration of therapy. Now, randomized controlled trials have shown that only 20 to 25% of HBe antigen seroconversion and 2 to 5% of HBsAg seroconversion is seen after 48 to 72 weeks of oral antiviral treatment in children. On the other hand, a spontaneous HBe antigen seroconversion rate of around 4% per year in more than 4 years of age in cases of perinatal transmission, and as high as up to 14 to 16% per year of HBe antigen seroconversion in cases of horizontal transmission is seen in children. Now, prolonged duration of antiviral treatment also increases the risk of resistance. The cumulative probability of emergent antiviral resistance after just 2 years of treatment is 2.6%. Similarly, the resistance to tenofovir has also been being reported in the case reports. Now, prolonged duration of treatment comes hands in gloves with the drug-related adverse effects. A discontinuation rate of 2% has been reported with entecavir treatment in children. Similarly, tenofovir adversely affects the bone mineral density, which is especially important in the growing age group. Now, potential biomarkers of relapse after stopping nucleoside treatment have also been studied in adults. However, there are no such studies in the children. Now, factors which are associated with decreased chances of relapse after stopping antivirals are female gender, younger age, nucleoside treatment duration of more than 2 years with HPV DNA undetectable, HPV DNA of less than 2000 IU per ml within 3 months of treatment initiation, a normal ALT levels for more than 5 years on antivirals, low HBsAg quant, HPV RNA, hepatitis B correlated antigen, and a higher level of anti-HP core antibodies. Now, circular covalently closed DNA seems to be the best prospective marker in this regard of predicting a relapse. However, it is still unclear if all cccDNA chromatin needs to be eradicated or if lowering it to a level of threshold where it can cause functional cure is possible. Now, unfortunately, no definitely proven serological surrogates for cccDNA is there, and accurate quantification technique for cccDNA is also yet not proven. So there are gaps in knowledge as there is lack of scientific data and literature to decide if treatment discontinuation in children with chronic hepatitis B can be done. There are no markers to predict relapse after treatment discontinuation, and efficacy of drugs in children with relapse hasn't been studied yet in children. So this study was planned with the primary objective to study the incidence of relapse and natural history after stopping antivirals in children with chronic hepatitis B, and with the secondary objective to study the predictors of relapse after stopping antivirals and to evaluate the efficacy and safety of peg-interferon alpha-2b in children with relapse. It was a prospective study conducted in Department of Pediatric Hepatology over a period of 2 years, which included children between 2 to 18 years of age who were on antiviral for at least 24 months, irrespective of their HBe antigen positivity status at the time of stopping treatment, with normal ALT levels with 3 consecutive readings done 6 months apart in last 12 months, having undetectable HBV DNA on 3 consecutive occasions 6 months apart in last 12 months. Patients who were on antivirals for less than 24 months had family history of cirrhosis or hepatocellular carcinoma, were having decompensation or SCC or co-infection with HIV or hepatitis C virus were excluded. So a study was designed, and after inclusion, the children were supposed to be assessed for treatment discontinuation by doing a liver biopsy, and if it showed a fibrosis of less than 3 as per the Shack grading system and HAI of less than 5, the treatment was supposed to be stopped. Now, CCC DNA estimation was also to be done in the liver tissue. Then they were supposed to be monitored and followed up at first month, followed by 3 monthly monitoring with relevant investigations. Now, virological relapse was defined as serum HBV DNA of more than 2000 IU per ml after stopping treatment in children with virological response, while biochemical relapse was defined as ALT levels of more than 2 times the upper limit of normal. Children who developed biochemical relapse are supposed to be given a sequential antiviral treatment. Now, CCC DNA levels were measured in the liver biopsy by a real-time PCR-based in-house assay on light cycler 480 instrument, which is a quantitative real-time PCR-based assay using cybergreen probes for the target detection. The primary outcome to be measured was the incidence of relapse after stopping antivirals, while the secondary outcome to be measured was the predictors of relapse after stopping antivirals and to evaluate the efficacy of peg-interferon alpha-2b in these children in terms of HBe antigen, HBsAg seroconversion, and reduction in the quantitative levels of HBsAg and HBV DNA. Since it was a pilot study, there was no data to base the sample size calculation, and all children, including fulfilling the inclusion criteria during the study period, were included. Relevant statistical methods were applied. Coming on to the results, a total of 114 children were screened during the study period, of which 39 children were included after application of inclusion in the exclusion criteria. Now, of these 39 children, 8 children became HBsAg negative by the time of inclusion in the study. Biopsy was not done and treatment was stopped. Now, rest 31 children where HBsAg was detectable, liver biopsy was done, and all of these 31 children showed HAI of less than 5 and fibrosis of less than 3. Treatment was stopped in all of these 31 children. Now, CCC DNA estimation was done in 24 of these children. Now, looking at the pre-treatment parameters in the cohort of our concern, that is the 31 children who were HBsAg positive at the time of stopping antiviral treatment, they were predominantly males. The median age of diagnosis was 10 years. 60% had history of vertical transmission. D was the most common genotype, and the median HBV DNA and HBsAg quant level was 6 and 4 logs respectively. All patients except one were HBe antigen positive. At the time of stopping antiviral treatment, the median age was 15 years. 42% had history of receiving sequential therapy, while 13 children were still HBe antigen positive. The median time taken for HBV DNA to become undetectable was 32 months, and they had received antiviral therapy for a median duration of 60 months, while the median duration of normal ALT was 30 months, and HBsAg count at the time of stopping antiviral treatment was 3 logs. All patients had HAI and fibrosis of less than 3 in the histology. CCC DNA was detectable in all the 24 patients where it was estimated with a median of 4.02 logs. Now, all the 39 patients in whom the treatment was stopped, among those, the 8 patients where HBsAg was not detectable and antiviral was stopped, there was no relapse even after 12 months of stopping antiviral treatment. While the 31 children where HBsAg was detectable, relapse was seen in 12 children. Now, 12 of the 31 children who had virological relapse, of these 5 children also developed biochemical relapse. Now, among the 12 children who developed virological relapse most commonly happened within 1 month of stopping antiviral treatment, while biochemical relapse happened between 3 to 9 months of stopping antiviral therapy. Now, looking at the characteristics of the 12 patients with relapse, the median time of virological relapse was 1 month, while it also happened as late as 9 months, while the median time of biochemical relapse was 6 months. Most of the patients who developed relapse were HPE antigen positive. SBHSG count in our study was on the higher side. Median CCC DNA at the time of stopping antiviral treatment was 4.19 logs, and all patients had completed 12 to 18 months of overall follow-up after stopping antiviral treatment. On univariate analysis of the parameters pre-treatment and at the time of stopping antivirus, it was found that the proportion of the patients who were HPE antigen positive was significantly higher in those who developed relapse compared to those where relapse was not seen. And the time taken to HPV DNA becoming undetectable was significantly higher in the children who had relapsed compared to those where relapse was not seen. CCC DNA was higher in the children who had relapsed, however, it was not found to be statistically significant. On Cox regression analysis, HPV antigen positivity at the time of stopping antiviral treatment and time to DNA becoming undetectable were the independent predictors of virological relapse after stopping antiviral treatment. This model predicted relapse with an AUROC of 0.855. Looking at these independent predictors individually, HBE antigen predicted relapse with a log rank of 10.705, and in this current study, 69.2% of those children who were HBE antigen positive relapsed compared to 16.7% of the children who were HBE antigen negative, which was significant. Now, at a cutoff of more than 22.5 months, taken for HBV DNA to become undetectable predicted virological relapse with a sensitivity of 88.3% and AUROC of 0.7432. In the current study, children who took more than 22.5 months for HBV DNA to become undetectable, 50% showed relapse against 18.2% who took less than 22.5 months. Now, 5 children with biochemical relapse received retreatment. 4 of them received sequential therapy. 1 received only oral antiviral as there was only transient transaminitis. Now, 2 children have completed 12 months of retreatment. Both received sequential therapy. Both have shown 2 log reduction in HbA count level. HBV DNA is undetectable in them and ALT is normal. Rest 3 children have completed 6 to 9 months on retreatment. None of the child has shown HBE antigen or HbA seroconversion. None of the children who were treated with sequential therapy developed higher grades of adverse effect or caused school absenteeism. The strength of this study is that it's a pilot study to investigate the natural history after stopping antiviral treatment children and adolescents with chronic hepatitis B. Well, the limitation is that it's a small sample size, although it is a pilot study, and longer follow-up may provide more definitive results. Hence, I conclude that the incidence of virological relapse was 38.7% and biochemical relapse was 16.1% after stopping antiviral treatment in children and adolescents with chronic hepatitis B, and HBE antigen positivity at the time of stopping antiviral treatment and more than 22.5 months of time taken for HBV DNA to become undetectable are independent predictors of relapse in children and adolescents with chronic hepatitis B. Thank you.
Thank you, Dr. Piyush, for your nice presentation. But I would say the number of the subjects included in this study is very small. Just I want to know anything new that you have told us in this study.
Sir, I want to refer to the ASLD endpoint conference, which says just a one paragraph about the children that there is no definitive evidence for stopping antiviral treatment in children because of lack of evidence. So it adds to the findings which have been proven in adults.
Okay. Now the talk is open for the comments or the questions also.
So, did we really expect the parameters or the factors to be any different in children than in the adults? These were children who were on an average about 10 to 11 years of age. Did we really expect anything different in them?
So, if we look at the recent evidences which are coming up in the literature like the 2020, which says that T cell exhaustion becomes more prominent with the increasing age. So they have done looked at it up from 3 to 4 years of age. So if the number would have been larger, we could have found something different with respect to age.
See, your
or the cccDNA in the liver tissue?
so in your relapsers actually come in two groups. Majority had within 1 month. So they were really, very different from the others that who relapsed between 3 to 9 months. Do you think there was any difference between the two groups?
Sir, the patients who had developed relapse within the 1 month were mostly those patients who had virological relapse. We didn't do any statistical analysis between the two as the number was very less, 7 and 5.
Biochemical response doesn't mean anything. 5 and 7, I'm not even looking at biochemical relapse. You have to wait a little while, and if you had not started them on treatment, they would also have got biochemical response, biochemical relapse, right? You started
Sir,
them off again.
Sir, 12 months have passed for the patients who have developed virological relapse, and those patients haven't developed biochemical relapse even
You have
after
not
12.
started them on antivirals? You have not started
So
them on antivirals?
patients who have developed only virological relapse are being monitored. Antivirals haven't been started yet.
Thank you.
Any other question or comment? If not, then we can stop here. And thank you, Dr. Piyush.
Thank you, sir.
I would invite Professor S.P. Singh to take up the next presentation.
The next presentation is by Dr. Shalimar from All India Institute of Medical Sciences, and he's going to present his work, Prevalence of NAFLD in India, a systematic review and meta-analysis. Dr. Shalimar, please.
Thank you, sir. At the outset, I'd like to thank the organizing committee for giving me an opportunity to present this analysis on behalf of my collaborators. I would also like to acknowledge Dr. Amit Goel, without whose help this analysis would not have been possible. We all know the global prevalence of non-alcoholic fatty liver disease. You'll see this figure in most conferences, data presented by most experts in talks. The NAFLD prevalence varies from, as reported with this meta-analysis, from 13.5% in studies from Africa to as high as 31.8% from Middle East. The NAFLD prevalence reported is around, in North America, is almost like 24%. In Asia, it is 27.3. Asia includes India with a population of 1.3 billion. No meta-analysis includes any studies from India. So the data what you hear regarding the prevalence includes all the whole world except India. We also know from this recent data published that the incidence of NASH cirrhosis over the past 30 years has almost doubled. And we know that in India, the prevalence of prediabetes, diabetes, and metabolic syndrome is on the rise. Prediabetes and diabetes reported in almost 20% each. Metabolic syndrome, almost up to 30%. We know NAFLD is associated with different components of metabolic syndrome. And the prevalence of prediabetes, diabetes, and metabolic syndrome is increasing in both urban and rural areas, as indicated by this recent meta-analysis published 2 months back. Available studies on NAFLD from India suggest that the prevalence of NAFLD in adults varies from 6.7% to 55.1%. It depends from which state, what kind of population was included. Was the study hospital-based or community-based? In children, the NAFLD prevalence is reported to vary from 7.3 to 22.4% in healthy population. The existing lacunae in the literature and the limitations include the small sample size of the patient included in the various studies, a predefined selection of patients, most studies including the high-risk populations, absence of data on the prevalence of NASH, which represents a severe form of liver disease. Therefore, in the absence of large sample size pan-India studies, the exact burden on NAFLD in India, where 1.3 billion population lives, is not known. Therefore, we raised a question that why not look at what is the prevalence of NAFLD as per the published data, and we decided to do this systematic review and meta-analysis of all studies published from India. A standard methodology for doing a systematic review and meta-analysis was used. We used the PRISMA checklist, searched PubMed, Embase, Scopus, Google Scholar, looked at all studies published till April 2021, which was the cutoff date. We included all studies reporting NAFLD prevalence on the basis of ultrasound. We included all age groups. We also included high-risk groups such as obesity, diabetes, and metabolic syndrome. Two independent reviewers screened all titles and abstracts of all studies. We extracted data as per the standard criteria and guidelines and presented that data. We divided the study population into different risk categories. Low risk, that includes athletes, aviation crew, and army personnel who are healthy, who are doing regular exercises as reported by the studies. Average risk, including community, participants of control arm, unselected participants, and those with hypothyroidism. And high risk as those with obesity, overweight, diabetes, coronary artery disease. We defined overweight and obesity as per the Asian criteria, that is BMI above 23 and 25 respectively. In the statistical analysis, NAFLD prevalence was summarized as proportions with 95% confidence interval. The heterogeneity between studies was assessed by the I-square statistics. The prevalence estimates from individual studies were pooled with random effect model because of marked heterogeneity among studies. We did a subgroup analysis taking a cutoff of 18 for defining adults and children. We also did an analysis on the gender, risk categories, and urban and rural populations. Coming to the results, a flow diagram of the study selection. We've identified 2570 studies. We assessed 89 studies full text for eligibility and finally included 50 studies. Coming to the pooled estimates of NAFLD prevalence, the basis of random effects model in children. A total of 8 studies were found that included 2903 children. 4 studies each were from school and hospital based. 4 studies included 560 subjects, that is included almost like 20% of the obese and overweight children. Overall NAFLD prevalence in children was 35.4%. Varied from non-obese to obese from 12.4 to 63.4. No difference between school and hospital-based analysis. Similar results in boys and girls. Coming to the pooled estimates of NAFLD prevalence on random effect model in adults, a total of 53 studies were there, 8 community-based, 45 hospital-based. Predominantly urban, 46. Total number of population included 23581. The data represented only 15 states and union territories. The gender-specific data was available only in 10,000 individuals. Overall NAFLD prevalence in adults, 38.6%. Males, slightly more than females, 39.4% versus 35.4%. Higher prevalence in hospital-based studies as compared to community, 40.8 versus 27.2. As expected, prevalence of NAFLD was higher in urban as compared with rural, 40.1% versus 29.2%. When we analyze the data on the basis of average risk and high risk adults, average risk, to reiterate again, included community, participants of control arm, unselected population, participants, and individuals with hypothyroidism. Prevalence, 30.5%. High risk included overweight and obese individuals, diabetes mellitus, those with coronary artery disease. The prevalence in this subgroup of individuals was 53.1%. We did a state-wise prevalence of NAFLD among the adult population. On the average risk population, there was a wide range of NAFLD prevalence, varied from as low as 11.9% reported in study from West Bengal to as high as 53.5% reported in Chandigarh study. Delhi studies reported 47.6%. When we looked at the high-risk population, the NAFLD prevalence was almost uniform, with most studies reporting NAFLD prevalence above 50%. It was as high as 60.4% in Delhi and 61.2% in study from Uttar Pradesh. Coming to the limitations, I think this is a very important slide and gives us an important message. Majority of the data which we found was from hospital-based studies. Only 15 out of the 36 states and union territories were represented. Most studies had small sample size. Very few were community-based, population-based studies. And importantly, the rural population is underrepresented in most studies done in India. We acknowledge the limitations of use of ultrasound as the modality for diagnosis of non-alcoholic fatty liver disease. It's subjective, has poor diagnostic accuracy for detecting mild steatosis, and has an associated inter- and intra-observer variability. We also acknowledge the fact there was significant heterogeneity between the different studies. We couldn't assess multiple aspects of NAFLD which we really aim to get data from this study. That includes the prevalence in different age groups, in between different BMI categories, lean versus obese, associated comorbidities, diabetes, hypertension, metabolic syndrome, PCOD. What happens to the outcomes of patients with non-alcoholic fatty liver disease? What's the difference in with the changing dietary patterns? Prevalence of NAFLD over time. What has happened to the prevalence over the last couple of decades? NASH versus lean NASH. Unfortunately, the most studies didn't report about these. So, in conclusion, the available data suggests that approximately 1 in 3 adults or children in India have NAFLD. And the important message which comes out is that we need good data. We need large studies with large populations across rural and urban to really assess the burden of NAFLD and plan for future. What's the real impact of this disease, which will be there in the next few decades. Thank you.
Thank you, Dr. Shalimar, for a very crisp presentation. The presentation is now open for questions.
So, Dr. Shalimar, this is Rakesh. You had a large amount of heterogeneity between studies. Did you undertake any meta-regression to assess the factors responsible for the heterogeneity? Also, we didn't hear about publication bias.
Right. So we did try to take into account, but because of the heterogeneity, small sample size, bit of so much of variability, unfortunately, we couldn't get very important results on those aspects.
I thought you had nearly 60 studies. So sample size important for that would be the number of studies. You had a large number of studies.
Correct, sir. But the number of individual samples per study were very less. So varying from few hundreds to maximum were around 1,000 or so. So there was a lot of heterogeneity. I agree to the fact that's a major important limitation of this analysis, but this also shows the important facts about studies published from India.
But that's true for studies all around the world also. For there is no standardization how you make a diagnosis.
Yes, correct. I agree to the fact, sir.
So how do we go from here? What does this number mean anything?
So I think it means a lot to us. One is why we did this study was because the recent study which we did on the prevalence of NAFLD, we found results of 50% both in urban and rural. So I thought, why not look into the data published from India? What we are seeing is the real fact or myth. I'm not sure what we could interpret from our own data. So we thought, let's look at the whole data published from India. It's very important data. I think we need to look at
Based on this, what do you think? Your data of 50% are fact or a myth?
I think it's a fact, sir. This is what we are seeing in the routine OPDs now.
Okay.
Even we have done a recent family survey. Every 1 in 2 of the family members of a person with NAFLD is now having NAFLD. We need to look into this. This is a fact.
So Shalimar, Dr. Saraswati, very nice study, enjoyed it. After having done all this hard work and reviewed the current literature, are you able to come to a suggestion or a proposal of what ought to be the optimal epidemiologic study to be carried out to take care of all the pitfalls and lacunae you have identified in your last slide?
I think, sir, it's the limitations I've highlighted. I think we need to now pool up across states, across cities. Everyone needs to pull up their own data together, maybe have Inasl as the guiding force, and go forward from here, collect data, and we will definitely get good results, and we can then plan out what's really would be the impact in the future, because this is the disease where we don't have a therapy available and the numbers are so high, it is an underestimate. I'll say this is also an underestimate of the real prevalence of NAFLD in India.
Thank you.
If there are no further questions, thank you, Shalimar, for a nice presentation. And now we'll have the next, the chairperson invite the next speaker.
Dr. Saraswat. Dr. Saraswat, are you there?
I think the timer needs to be stopped. The presentation has not started.
Dr. Singh, you can continue. I think there must be some connectivity issue with Dr. Saraswat there.
Okay, the next presentation is by Dr. Shweta Palnichami. She's from the Institute of Liver Diseases and Transplantation, Dr. Rela's Institute and Medical Center at Chennai, and she'll speak on religious fasting impact on liver parameters. Shweta, please.
Thank you, sir. Am I audible, sir?
Yeah.
Yeah, thank you. I'm Dr. Shweta, Junior Resident from Institute of Liver Disease and Transplantation, Dr. Rela Institute and Medical Center, Chennai. My topic is about religious fasting and its impact on liver parameters. As we all know, fasting is a ritual followed across several religions around the world. Observation of fasting can vary from a day to a month approximately. There is a gross difference between starving and fasting. Starving speaks of chronic and severe decrease in calorie intake, while fasting describes about the negative energy balance, which means where there is going to be decreased energy intake in contrary to increased energy expenditure. Unlike dieting, there are different types of fasting, and there are different types of fasting followed across the world. One of them, intermittent fasting.
Muted the mic actually. So,
one of them is intermittent fasting.
Yeah.
Intermittent fasting happens. Intermittent fasting is a fasting that goes around 14 to 16 hours of complete abstinence of consuming food or drinks. While there are different types of fasting, like periodic fasting, that includes around more than 24 hours of complete abstinence from consuming food. Intermittent fasting also is similar to religious fasting. The only difference is religious fasting has a complete abstinence even from water. Here, there are so many studies on the effect of religious fasting on biochemical parameters. Though there are very widely studied parameters on different biochemical parameters, now we are going to study the effect of fasting on liver-related parameters as it is not widely studied. Our main aim and objective is to evaluate the effects of fasting on metabolic parameters. Our study is a prospective observational study that was conducted on healthy volunteers who underwent religious fasting between 13th April and 12th May 2021. So they had a period of 14 to 16 hours of no food or drink, which was followed by a regular diet. This happened over a period of 30 days. The following tests were conducted before the commencement of religious fasting and after the completion of religious fasting. Body mass index, abdominal girth, LFT, fasting lipid profile, and fibroscan parameters were also checked. No special diet was advised in our study, and the volunteers were recommended to continue with their usual diet. And there was an individual diet and exercise pattern that we recorded using a questionnaire. The statistical analysis was performed with the use of SPSS software. And to compare the characteristics before fasting and after fasting, we used Wilcoxon sign rank test. While to test the differences in the calorie and protein intake, again, pre-fasting, during fasting, and after fasting, we did a Friedman test, that is a non-parametric test. As we all know, a p-value of less than 0.05 was considered statistically significant. Our results are shown as follows. The male is to female ratio is around 2:1. There were among 18 healthy volunteers that in our study, and the median age was 26 years, and the interquartile range was about 23 to 39. In our study, among 18 volunteers, only one had idiopathic hypertension. Physical activity has a large impact on metabolic parameters. Therefore, we also did a questionnaire-based study for the physical activity amongst the 18 people. Among the 18 people, 7 had a usual physical activity in their day-to-day routine, which means 38% of them had a performance activity, while 61% did not. Among the 7 people who had a usual day-to-day routine of physical activity, 66 minutes per day they spent on hours of workout. We also took a mean calorie intake and a mean protein intake by the base of questionnaire. As you can see, the pre-fasting and post-fasting was much larger when compared to during fasting. Before fasting, the calorie intake was 1,500, while after fasting was 1,400. This can be taken significant because the tests were done only plus or minus 2 days before the fasting and plus or minus 2 days after the fasting. As you can see, in contrary to many studies that were done in various global regions, in our study, there was significant decrease in calorie intake. Between the pre-fasting and during fasting, we did a statistically significance rate where the p-value was 0.00. There was another protein intake that we did before fasting and after fasting. The protein intake was high when compared to during fasting, and this was also statistically significant. The following parameters that are going to follow did not show significant changes between the study. Weight and BMI always has a positive correlation. Before fasting and after fasting, as you can see, both weight and BMI did not show much of any change. This is very significant because there are many studies before, especially there was a study in 28 obese individuals where there was a decrease in weight and BMI when they had a balanced diet. This also mentions about the calorie and protein intake that has to be taken importance of. Next, we have the liver function, that is the total bilirubin, that showed very minimal increase in total bilirubin after fasting. And the liver enzymes, AST, ALT, GGT, and ALP, did not show much of any increase or decrease between the 2 study periods. Here, we also see a graph that is plotted for glucose, blood urea nitrogen, and creatinine. Our study correlated, it was consistent with much before studies where blood urea nitrogen and creatinine was similar, while glucose was also similar. Previous studies show there was not much any significance with blood urea nitrogen and creatinine. Here, we also see the lipid profile that did not have any change pre-fasting and post-fasting. HDL and total cholesterol was not much of any significant change. Fibroscan parameters. We also wanted to check the fatty change and the amount of fibrosis in these healthy volunteers. The controlled attenuated parameter score checks the amount of fatty change, while the liver stiffness checks the amount of fibrosis. So as we can see, the mean value before fasting was 242, while post-fasting was 224, which was a very minimal decrease, though not very statistically significant, while the stiffness score did not show any statistical significance. Now, the ones that is going to follow are going to be the significant changes before and after the religious fasting. This is a line graph that shows a mean value of the abdominal girth before fasting and after fasting. As you can see, the mean value was 35 centimeters before fasting, while there was a significant decrease in post-fasting. This can also be correlated with the decrease in calorie and protein intake during fasting that has attributed to the decreased abdominal girth in post-fasting. This shows statistical significance of p-value of 0.020. Next, we come to the albumin level. The albumin level was significantly increased after fasting. This increase in after fasting might be pertained to due to the hemoconcentration that was attributed due to dehydration during Ramadan. Since they have a complete abstinence of both food and water, since the test was also taken just plus or minus 2 days after the fasting, this increase in albumin can be taken statistically significant. The mean value before fasting was 4.67, while after fasting was 4.77. On the contrary to albumin, there was a decrease in total protein intake. This can again be related to the decreased protein intake that was taken during fasting period time. The mean value before fasting was 7.87 grams per deciliter, while post-fasting it was 7.57 grams per deciliter. The triglycerides level also show a drastic increase in triglycerides levels after post-fasting. Before fasting, the mean value of triglycerides was 80 milligram per deciliter, while post-fasting, it was 105 milligram per deciliter. This can be related despite decrease in calorie and protein intake, because during Ramadan, there would have been an increased carbohydrate intake, and that's why they had an increased triglyceride level. On the contrary, there was decrease in LDL pre-fasting and post-fasting in comparison, and the p-value is 0.041. In conclusion, there was no shift in weight, while the abdominal girth significantly reduced after completion of religious fasting. Despite reduction in calorie and protein intake during religious fasting, there was increase in triglycerides. While the albumin levels were high, the total protein was significantly reduced. That might be again attributed to decreased protein intake, while the liver enzymes and CAP score remained stable. The one take-home message that I would like to say, religious fasting is associated with reduced abdominal girth, reduced LDL cholesterol, decrease in protein, and increase in triglycerides. So a consumption of appropriately balanced diet may enhance the benefits of this religious fasting, since there was a bigger limitation in our study, since there was no proper diet that we advised during fasting. And again, a limitation of our study is the decreased sample size. So we were not able to attribute it. We do need an increased sample size to actually go with this. Thank you.
Well, can you please stop sharing your screen? Thank you, Dr. Shweta, for an interesting presentation. I'm sure there'll be a few questions on this presentation, but just to set the ball rolling, you studied this. What was the duration? I missed was the entire Ramzan period, 30 days, the duration of religious fasting?
Yes, sir.
Right. So why, I mean, what exactly was the motivation or the reason for you to study it? did you really expect any major changes or having any impact on the health of the individual? Or you want to look at it as a tool that may be used more regularly for weight loss?
Definitely, sir. There is either way. One is because there is no control to show that Ramadan fasting has an effect on other chronic disease people. So we can have these healthy volunteers as a control if we have a larger sample size. Since it's a smaller sample size, we cannot come to a conclusion. With a smaller sample size, with a larger sample size, we can still have a control group for in comparison with the chronic disease people. Likewise, type 2 diabetes people and for chronic liver disease people.
So you have the sample size problem you've addressed as a significant limitation in your study. 18 is a very small sample size.
Yes.
But the weight change also was barely about 100 grams that I could make out from your charts.
Yes,
with
sir.
that, the abdominal girth measurements, etc., could that have been merely an artifact of measurement of abdominal girth? Because a month apart, two measurements, a centimeter above or below, might give you that much difference. So
Definitely. That could be a
Did you
limitation.
correct for that?
That could be a limitation, sir. But pertaining to the decreased calorie and protein intake that they had during fasting, and we took the measurement only plus or minus 2 days after fasting. So that could have attributed to the abdominal girth.
Well, okay. Dr. Rakesh, you have a question?
Dr. Shweta,
Yes,
you
sir.
found no change in weight, but a reduction in girth. Isn't it unusual? And the reduction in girth was primarily in one subject from 56 to 36. It was written as centimeters, I suppose it is inches.
Yes.
How do you explain this reduction of girth by about 1/3 in one of the volunteers?
Sir, we spoke to the specific individual. So that person took this Ramadan fasting as a term of weight loss. So he actually followed a balanced diet.
So is that person really something that should be included in this analysis? Secondly, if there is no reduction in weight, how do we propose dehydration as the cause of increase in abdomen? Dehydration should also have led to a reduction in weight, right?
True, sir. So that can be an artifact also.
The third thing is, you said there may be increased carbohydrate intake. Calories 1562 gram protein, right?
Yes,
that comes to about 4 gram per 100 calories. During fasting, 1100 calories, 50 gram protein.
Yes,
right?
sir.
If anything, the amount of protein as a proportion of total calories increased during fasting, and carbohydrates must have come down. So I don't think we can really say that that was responsible. Over as far as I'm concerned. Yeah, meaning you can respond. I mean, I don't have any other questions. That's all I will say.
Yes, sir. The thing is, we didn't actually follow a proper diet. That was a big limitation, and that's why we have a drastic change during fasting and after fasting, I believe.
See, as a matter of, if we get away, eating at fixed times has been a relatively recent phenomenon in the evolutionary history of humans. I don't think nature ever wanted us to eat at fixed times. It wanted us to eat whenever food was available. So really, I wouldn't even expect this to make a difference.
Okay.
Yeah, I guess we are running out of time now, although there are questions in the chat box. So maybe I'll hand over to the chairpersons.
Dr. Abhijit. Dr. Abhijit, are you there to invite the next speaker?
Okay, let me introduce the next speaker. We now have Dr. Swapnil, who will be talking about optimal cutoff of controlled attenuation parameter with MRI for the diagnosis of hepatic steatosis. Dr. Swapnil, please.
A very good evening, and first of all, I would like to thank the Inasl team for giving me an opportunity to present our experience in this topic. Are my slides visible?
Yes, they are.
Just go to full screen, please.
Yeah. I'm going to present our experience regarding the correlation of FibroScan and MR-PDFF for the detection of liver steatosis. So what should be the optimal cutoff of CAP, that is the control attenuation parameter, with MR-PDFF as a reference standard for detection of liver steatosis? So how do we assess liver steatosis? So it can be assessed invasively or non-invasively. Invasively, the biopsy, liver biopsy is the gold reference standard. However, it comes with its own sets of adverse events and also has some sampling variability because of focal fatty involvement. The non-invasive strategies are predominantly with biomarkers and imaging, and we most often make use of imaging in the clinical experience, of which ultrasound is the first line which we use, which is sort of less accurate and operator dependent as compared to CT and MR. CT involves radiation exposure and is often inaccurate in appropriate quantification of steatosis. MR is currently the non-invasive reference modality for a quantification of steatosis, and MR spectroscopy is performs better, however is not widely available, and MR-PDFF correlates well with MR spectroscopy and histology proven steatosis. FibroScan, that what we call it as a volume controlled transient elastography, also correlates well with histological grades of liver steatosis. So what is the difference between FibroScan and MR-PDFF? So each modality has its own sets of advantages and limitations. FibroScan has good diagnostic accuracy, it's easy to perform, the results are instantaneous, it's relatively cheaper, and you can go for co-assessment of stiffness measurements. However, FibroScan is affected by multiple factors like body mass index, ascites, visceral fat, the skin to capsular distance, the width of intercostal spaces. MR-PDFF is a newer modality and is used for fat mapping of the entire liver, and fat fraction can be assessed in any segment of the liver, what we call it as a region of interest, and has lower cutoff values. The limitations is that it is not widely available and the accuracy can be affected by fibrosis and severe steatosis. So understanding the basic concept of CAP score on the FibroScan. So control attenuation parameter basically measures the dampening of the ultrasound waves and gives us an estimation of amount of steatosis. The widely accepted range of CAP for steatosis from S1 to S3 are very high. The cutoff score of 238 to 260, it is the amount of liver fat is considered as 11 to 33%. S2 is 260 to 290, and the amount of liver fat that it predicts is 34 to 66%, and higher than 290 is 67% or higher. However, in clinical practice, we do see often a dissociation between these CAP scores and the amount of fat present in the liver. And these CAP scores differ depending upon the population study. As compared to US and Eastern, there is wide difference in the CAP scores. If we see in Korea, S1, the cutoff of CAP for detecting S1 is 250 decibel per meter, as opposed to USA from Dr. Lumba's study, it's 288 decibel per meter. So there are very few studies. What could be the optimal cutoff of CAP in India? There is only one study by the All India Institute of Medical Sciences, which has given a cutoff in obese and non-obese patients. However, they have used FibroScan with histology without using PDFF. So the aim of the study was to examine the diagnostic accuracy and optimal cutoff values of CAP for diagnosing liver steatosis with MR-PDFF as a reference, particularly in North Indian population. The inclusion criteria of the study were adults aged 18 years and above, and we used two cohorts of patients who were having with or without NAFLD. So the first cohort was taken from the DLIF cohort, that is the dapagliflozin study, the dapagliflozin study, in which we had taken almost 115 odd patients who received dapagliflozin for a period of 6 months, and we had the MRPDFF at baseline and after 24 weeks. And the another cohort was of normal patients. So the first cohort had patients who had type 2 diabetes. However, the second cohort were patients were healthy individuals who were being evaluated for living donor liver transplantation. So they were predominantly premorbidly healthy. They were not having any comorbidities per se. And during the liver donor evaluation, they were subjected to MRPDFF or biopsies, depending upon if they had presence of more than 2 metabolic factors or have borderline liver volumes. The exclusion criteria were patients who had significant liver disease in the form of viral marker positivity, raised transaminases at presentation, significant alcohol consumption, drugs causing fatty liver like tamoxifen, amiodarone, any other factors which can rise to for falsely elevated non-invasive assessment of steatosis and fibrosis like congestive heart failure, pregnancy, end-stage renal disease, and in patients who in whom we were not able to measure a valid fibroscan measurements or who had contraindications to MR. So coming to the derivation cohort, of total 168 patients assessed for eligibility, 18 patients were excluded who had features of liver disease in form of cirrhosis, chronic hepatitis, significant transplantation or alcohol intake, or who declined to participate, of which 150 eligible participants, 13 were excluded because of lack of adequate data, like missing CAP data or missing MRI PDFF data. So total 137 patients were included from these two cohorts, the DLEAF trial cohort and the ongoing cohort of prospective liver donor healthy individuals. So out of these 137, 23 patients underwent liver biopsy who were being evaluated for liver donation. So coming to results, so these are the baseline characteristics of cohort. If you stratify them by NAFLD status, that if they have a NAFLD defined by MRPDFF less than 5%, no NAFLD, and NAFLD if it's more than 5%. So about 83 to 85% of patients had NAFLD. The baseline characteristics, patients had a mean BMI of 28 kg per meter square, and males were predominant. Patients who had NAFLD had significantly deranged liver functions as reflected by raised transaminase and raised gamma GT, and also the lipid profile was deranged. The mean CAP value was 303 in total cohort, and there was significant difference of CAP between NAFLD and non-NAFLD patients, 230 versus 316. Mean LSM was 8.4, and it was 4.8 in non-NAFLD cohort versus 9 in the NAFLD cohort. Mean MRPDFF value was 13 in the overall cohort, and it was 3.5 in the non-NAFLD and 14.9 in the NAFLD cohort. So if we have a look at the patients, 23 patients who had underwent liver biopsy for the purpose of liver donation. So they were largely younger patients with a mean age of 34 years and a BMI of 26.3. The mean liver fat content was 6.3 by MRPDFF, and by CAP it was 266. So out of these 23 patients, 12 patients did not had any evidence of steatosis, be it on MRPDFF or on biopsy. If we study the baseline characteristics, if we stratify them by BMI, so there was significant difference of CAP. CAP was higher in patients who had BMI of more than 25 kilogram per meter squares, and also the liver fat content as assessed by MRPDFF, 7% versus 14.3%. So these were the baseline characteristics. And now we will see how the MRPDFF and CAP correlated. So the CAP correlated positively with MRPDFF values with an R value of 0.679. So there was a positive correlation as the CAP value increased, there was significant increase in the MRPDFF values also. So it was not only the correlation between MRPDFF and CAP, but there was significant correlation with other clinical and biological variables. Like MRPDFF did correlate with BMI, with lipid profile and liver functions. And so also the CAP correlated with BMI. It was higher in patients with higher BMI It was higher in patients who had dyslipidemia, and also patients who had high CAP had high liver enzymes. So coming to the distribution of CAP, if we stratify them by the liver fat content in MR-PDFF, that is no steatosis, less than 5%, 5 to 10%, and more than 10%. So there was significant difference in the CAP value between patients who did not have steatosis and patients who had mild steatosis, that is 5 to 10%, of around 230 in patients who did not have steatosis and 2 versus 280. And if we compare it with more than 10%, it was 280 versus 340 CAP. Coming to the diagnostic accuracy of CAP for detecting liver steatosis. So the aura of CAP for detecting liver steatosis by MR-PDFF more than 5% was 0.93 at a cutoff of 262. The aura of CAP for detection of steatosis by MR-PDFF more than 10% was 0.89 at a cutoff of 295. And the AROC decreased to 0.78 for detection of steatosis more than 20% at a cutoff of 324. So to summarize this in a tabular form, as the amount of steatosis increased from 5% to 20%, obviously the cutoff values were different from 262, 295 to 324. And as the amount of steatosis increased, there was significant decrease in the sensitivity. So if we see that at an MR-PDFF of 5%, the cutoff of CAP was 262. By that, I would like to say that if a patient had a CAP of 262, there was a significant chance that the positive predictive value of 98%, that almost 98 of 100 patients had more than 5% fat on MR-PDFF. So CAP is, so at an optimal cutoff of 262, we can reliably differentiate patients who had steatosis, presence of steatosis more than 5% or not. However, as the grade of steatosis increases, the sensitivity and specificity goes on decreasing. So CAP showed an excellent diagnostic performance for differentiating presence and absence of liver steatosis. However, this accuracy was poor in evaluating between grades of steatosis. And as the steatosis grade increases, the diagnostic accuracy for identifying steatosis decreases. So these are some of the salient features of our study, that it involved prospectively recruited cohorts. There was a standardized assessment for presence of liver disease, and patients who had significant liver disease were excluded. We used MR-PDFF technique in our patient profile. And the most important factor was a liver biopsy was done in a significant proportion of participants. 23 out of 137, roughly around 17% of patients underwent liver biopsy. And these were patients who were premorbidly healthy. They did not have any disease, and the biopsy was done solely for the purpose of borderline liver volumes or presence of 1 or 2 metabolic factors, depending upon the clinical context. So this makes our study different from whatever studies we have in literature from India and also from out of India, from US, Korea and China. So majority of studies were carried out in patients who had fatty liver or diabetes, type 2 diabetes and metabolic syndrome. And we were able to achieve a novel optimal cutoff of 262 decibel per meter of CAP to differentiate between steatosis more than 5% and less than 5%. The limitation is that it's a single center study conducted at tertiary care center, predominantly reflects North Indian population, and may not be applied in general. Thank you.
Dr. Rakesh, you're muted.
Any questions by anyone? Can we go to your slide 15 or 16? how many people had steatosis less than 5%? Please.
So there were 23 patients who had steatosis.
The next one, please. So basically, it was accurate in only 23 out of so many people, right? The aim really is not to identify people who do not have steatosis, but to identify people who have steatosis.
Yes,
Significant
aim is to identify people who have steatosis more than 5%.
Can we go to slide 15, please? One more. Yeah. So if you see if you see 262, right? So many people in the pink group have value below 262, right? Of those who are value below 262, only about half are blue dots and rest of them are pink dots. So even for that, the specificity is going to be very poor. I'm using this as a teaching point. You know, area under curve or something does not tell you. You really need to see the sense, multiple factors. If you see this, you are going to have very poor. You will going to have difficulty even if the value is below 262. Any other questions? So there is a question in the chat box. BMI is missing in biopsy. How it was adjusted? Can somebody make it more clear? I don't know. Anybody else has any question?
So we did take BMI into consideration, and we have also divided cohorts depending upon the BMI, less than 25 and more than 25.
Can you go to the next slide? What does the area under curve in the next slide mean really? No, the lower, the other direction, right? So again, your cap cutoff of 262. How have you derived it? This is using the Uden's index, or how did you do this?
Yes, sir, using Uden's index.
Okay. No other questions, and so I think we'll stop here. Thank you. And I'll request Dr. Harshad Devargavi to take over, please.
Yeah, may I now invite the next speaker, that is Shivabhadra Mahapatra from Government Medical College, Thiruvananthapuram, to present her study, please.
Good evening, respected teachers. My slides are visible, sir?
Yes, quite clearly. Go ahead.
Good evening, respected judges, my teachers and my colleagues. I am presenting the topic regarding renal resistive index and intra-abdominal pressure as predictors of hepatorenal syndrome in decompensated chronic liver disease patients, a prospective cohort study that done in Government Medical College, Thiruvananthapuram, Kerala. Hepatorenal syndrome is a life-threatening complication of cirrhosis characterized by renal arterial vasoconstriction. Pointer. Volume is coming. Volume coming.
Your volume is fine. Go ahead.
Our aim of the study was to study the renal resistive index as a predictor for the development of hepatorenal syndrome in decompensated chronic liver disease patients over a period of 6 months. We also studied the association of intra-abdominal pressure that measured at the time of ascitic fluid tap in decompensated CLD patient with tense ascites and for future development of HRS over the period of 6 months. Ethical clearance was obtained from Hospital Ethical Committee. Written informed consent were obtained from all patients in local and local language and English. No additional expenses were put on the patients and caregivers. Materials and methods. This is a prospective single center cohort study that performed at Government Medical College, Thiruvananthapuram, July 2019 to July 2020. Baseline clinical parameters, renal resistive index, and intra-abdominal pressure were obtained at the time of enrollment. And 10 societies was ascertained as mentioned in EASL Clinical Practice Guideline 2018. We included all patients with decompensated cirrhosis as defined as CTP score of more than equal to 7 attending the Department of Medical Gastroenterology during the study period, and we excluded the patients who are not willing to give consent, upper GI bleed, sepsis AKI in previous 1 month with coexistent chronic kidney disease, malignancy, severe cardiopulmonary disease, and technical difficulties in measurement in RRI and intra-abdominal pressure. RRI values were measured initial presentation at interlobar arteries of each kidney. As renal vasoconstriction basically progressed from hilum towards the cortex with the severity of the ascites. And this RRI value was done using the Doppler ultrasonography in our department. RRI computed using the formula of peak systolic velocity, peak systolic velocity minus end diastolic velocity divided by peak systolic velocity, and the normal range of values of RRI according to the previous studies was 0.6 to 0.7, and hence RRI of 0.7 was considered as a threshold value indicative of increased renal vasoconstriction. We measured intra-abdominal pressure in patients with 10 ascites. An 18 gauge needle was gently inserted into the abdomen as per conventional ascitic tapping, and the opening pressure can be assessed by measuring the height of the vertical column of the ascitic fluid in centimeter as described in the diagram. This was taken from Royal College Hospital guideline of Melbourne. For measurement of IAP, we ensured the horizontal surface by using the spirit level so that, to ensure precision. On follow-up, the patients were followed up for 6 months to look for the development of hepatorenal syndrome according to the IAC criteria. Statistical analysis was done using SPSS version 25. ROC curve was plotted to find out the best cutoff value of RRI and IAP for prediction for development of HRS. Area under the curve, sensitivity, specificity, and predictive values were calculated for prediction of development of HRS, and multiple logistic regression was used to predict the independent risk factor of HRS in 6 months. We screened 155 patients. Among them, 25 patients met exclusion criteria, and we enrolled 130 patients, 10 patients lost to follow, and among 120 patients, RRI measured at initial presentation to the hospital and followed up for 6 months to look for development of HRS. And in 60 patients, we measured intra-abdominal pressure at initial presentation with 10 ascites, looked for 6 months to look for development of HRS. Baseline characteristics of the patient, we got that alcohol-related etiology as most common etiology of 50%, and NASH-related etiology at 30.8%. Child B and child C are comparable, and average RRI value we got as 0.76 plus or minus 0.05. The average RRI value was 0.76 plus or minus 0.05 with a median value of 0.74 with a minimum value of 0.7 and maximum value of 0.9. The average RRI value among the males and females were comparable. We also studied the association of RRI with selected variables and found that presence of 10 ascites, presence of clinical jaundice, and child C status, the mean RRI value was higher as compared to other groups. There was also a positive correlation of RRI with increasing male sodium score. As the RRI values are increased, the increasing severity of the liver disease also increased. HRS we got in 24 patients, that is 20% patients during follow-up, and patients with mean RRI of 0.82 at initial admission developed HRS during follow-up, and patients who developed HRS on follow-up had higher male sodium score than who not developed HRS. So we plotted a curve, area under the curve, and we got a best cutoff value of more than equal to 0.77 with an area under the curve of 0.89, and with a sensitivity of 91%, specificity of 76%, positive predictive value of 48%, and negative predictive value of 97.3%. We also compared the groups between NAS and non-NAS etiology, and we got that NAS etiology more than 0.7, more than equal to 0.77 with the area under the curve was 0.91. And for non-NAS etiology, it was more than equal to 0.82 with the area under the curve was 0.91. On multivariate analysis, NAS-related etiology of cirrhosis was found to be an independent predictor for the development of HRS with a significant p-value. We also compared two groups, that is RRI more than equal to 0.77 and RRI less than 0.77. And we found that presence of clinical jaundice, child C status, higher MELD sodium scores, presence of tense ascites, and HRS in 6 months were more in the groups where RRI value was more than 0.77 than the group less than 0.77. We also evaluated biochemical parameters and got that prolongation of prothrombin time and INR along with total bilirubin, higher total bilirubin and lower serum albumin in more than 0.77 group as comparison to less than 0.77 group. We measured intra-abdominal pressure in 60 patients with tense ascites at the opening pressure at the ascitic time of ascitic fluid tap, and the mean value of IAP we got at 17.12 centimeters of ascitic fluid with a range of 10 to 25 centimeters and the median value of 16 centimeters of ascitic fluid. Patient who developed HRS had average value of 20.6 centimeters of ascitic fluid. We studied IAP as a predictor of HRS in 6 months and got an area under the curve as 0.93 with an optimum cutoff value of more than equal to 0.17 centimeter of ascitic fluid with sensitivity of 83% and specificity of 94.44%. So I'm going to discussion the average RRI value we got in our study was 0.76. The normal range of RRI value was 0.6 to 0.7. Our study showed that RRI was elevated in cirrhotics that was similar to the findings of other studies. This could be because of renal vasoconstriction that occurring in cirrhosis, which may be due to imbalance between renal vasoconstrictor and renal vasodilators in cirrhosis. We compared our study with two other studies. Got an average RRI value of 0.76 in our study in study done by Mohsin et al. 30 patients they studied and they got a value of RRI 0.77 as a diagnostic of HRS. Sandeep Goyal et al. They studied and found that renal resistive index of more than 0.7 is a significant independent predictor for subsequent development of HRS. We studied NAS-related etiology as an independent predictor for the development of hepatorenal syndrome, which was not studied in two other studies. Other factors that are associated with higher RRI in our study: tense ascites, clinical jaundice, blood urea creatinine, higher CTP, higher MELD score, higher intra-abdominal pressure, lower serum albumin, and prolonged INR. We got. And as comparable to Mohsin et al., they also got similar type of results like jaundice, encephalopathy, tense ascites, blood urea, and creatinine. At Sandeep Goyal study, their RRI value was significantly higher in cirrhotic patients as compared to healthy controls, and RRI was significantly greater in patients with ascites greater than without ascites. So in our study, we found that raised intra-abdominal pressure is a strong predictor of hepatorenal syndrome as noted in area under the curve as 0.935. And raised IAP can lead to compromised renal circulation, renin release, thereby aggravating the renal arterial vasoconstriction, which can precipitate HRS. We compared our study with one study done by Umgelter et al. They found that reduction of intra-abdominal pressure by 60% and a significant increase in creatinine clearance after large volume paracentesis with albumin infusion. And in our study, raised IAP, we got more than equal to 17 centimeters of ascitic fluid is a predictor for development of HRS in 6 months. Limitation of our study was conducted in the single center study, and IAP was not measured by conventional method of saline instillation into the bladder with manometry using an expensive transducer. Further studies are required to assess the relation between the number of taps, liter tap, and whether reduction in IAP will translate to reduced incidence of HRS or not. So on conclusion, measurement of RRI and IAP are novel screening tools that predict the development of HRS in decompensated cirrhosis. These are easy bedside tools for predicting the HRS in patients, and NAS-related etiology is an independent predictor for the occurrence of HRS. Thank you.
Yeah. So Shivabrata, thank you very much. If I can start the first question, how do you plan to use the information you got in the patients that you will be seeing in the future?
Sir, information, sir, actually after 6 months we have not followed. After 6 months, we can follow the patient further for 1 year and 2 years to look for development of HRS or HRS-AKI in these patients. And second thing is that NAS-related etiology we found as a predictor. So we have to again study more in regard to etiology of the like NAS, non-NAS, to alcohol-related also to validate the study.
Any questions from my other colleagues?
Yeah, I think an interesting study. My question to you would be, in the cohort you followed, what was the interval between the detection of your cutoff value of the RRI and the actual development of HRS? You followed them for 6 months, but the interval was days, weeks, how long? And what was the actual value? I mean, did you measure the actual value of RRI at the time when you diagnosed HRS?
Actually, sir, patients are followed every monthly to our OPD. But when basically we, after 6 months, we whether HRS development was there or not, we studied. In between, like 1 month, 2 months, we have not studied separately. Actually, this should be studied in future studies to look for whether 1 month or 2 months or 6 months there is development.
Yes, but many people would argue that an RRI of 0.8 probably already reflects present hepatorenal physiology, or hepatorenal syndrome is already present. So depending on the criteria you use to diagnose HRS, you might actually have found a very short interval of the patients at the time of detection of any RRI above 0.8 were already in HRS. So how did you try to look for this aspect? Why wait 6 months before you diagnose the HRS?
RRI value, sir, normal RRI value is 0.6 to 0.7. So, but 3 or 4 studies are there. One have given more than 0.70 as a cutoff for detection of HRS. One have given 0.73.
I think just to stick to the interval at which you diagnosed RRI and the therapeutic implication of diagnosing HRS and its treatment are so serious that one would want to diagnose HRS as soon as possible and not wait for a period of time. Right. So that's the point I wish to make in your study. Please, next question.
So if we look at your data,
yes,
these patients had many other factors such as presence of ascites, prior urea or creatinine, etc. Did you try to assess whether RRI added anything to what could have been predicted based on simpler measures? Over.
Sir, RRI we got in our study like 0.77, more than equal to 0.77. Other factors also studied in our study, like
so is it possible that other factors by themselves would have predicted well who will get HRS and who will not? Did RRI add anything?
RRI we got in our study, RRI and IAP are more predictors than other factors like 10 ascites, lower serum albumin, and clinical jaundice, higher MELD sodium score.
See,
but RRI and IAP
available. This is something you have to do additional. So if you can diagnose based on those factors themselves, why look for another additional measure?
RRI and IAP are good measures. We can do it easy and simple methods. Other measures also can be done, and further studies are required whether other blood labels are predicted or not.
Kaushal, I think we are done. So Shivabrata, thank you very much for your study.
Thank you, sir.
Thank you very much,
Inasl, for giving me such a platform to speak.
Yeah, thank you.
Thank you. And that was a very interesting session with the innovative data produced by many researchers. And I thank the judges of the session, Dr. Rakesh Agarwal, Dr. Dhiman, Dr. S.P. Singh, Dr. Vivek Saraswat, Dr. Abhijit Chaudhary, and Dr. Harshad Devarbhavi for first selecting these 6 papers and now judging them. And we will have the results soon. And it will be announced, the first and second prizes will be announced in the valedictory function tomorrow close to 9 p.m. So I request all the participants to be present there at the time for the announcement of prizes. So now we move on to very important sessions, the 2 orations of Inasl, very prestigious orations being awarded to very famous personalities. These are the Dr. N. Madan Gopalan oration and Dr. S. Memorial oration. So for this, I would like to invite the chairpersons, Dr. Roop Rai, Dr. V.G. Mohan Prasad, and Dr. Virender Singh to take the floor and start the session. Dr. Roop Rai, please.
Good evening. At the outset, I wish to thank Inasl for giving us an opportunity to be the part of this prestigious oration program. Professor N. Madan Gopalan was a giant in the arena of hepatology and gastroenterology in India. He did his MRCP from Edinburgh University in 1960 and in the special subject of alimentary diseases as his special subject. On return to India, he established the Department of Gastroenterology in 1971 and started DM course in Madras Medical College. He had passion for probing into the unsolved problems in the field of hepatology, may it be viral hepatitis, subacute hepatic failure, or role of adulterants as carcinogens in the development of HCC. This culmination culminated in the over 200 publications to his credit. He was a teacher of teachers because he trained so many people, and out of them, they have contributed in the development of gastroenterology in India. And Professor N. Madan Gopalan oration was instituted by Inasl in 2003 to commemorate in his memory and his contributions in the field of gastroenterology in India. May I now request Dr. V.G. Mohan Prasad to speak about the presenter for today, recipient.
Sir, you are muted. Sir, you are muted.
Yeah, I'm sorry, I don't have the biodata to introduce, but I think it's Professor Mohammad Reela who's going to speak, right?
Yes.
Yes, Mohammad Reela, doesn't require any introduction to this audience or even global audience, because he's a man who's an innovator of doing liver transplants, especially the first split liver transplant for a baby he saved, a neonate he saved in UK. Made him a historical figure, because even today, the person is alive and doing well. And it was really very interesting to see Professor and also the patient, both joining hands and giving a broad grin, and he was in all the media. So he is a man who brought in liver transplantation to India in a big way. And even today, most of the centers are doing cadaveric transplants, but he's one center in South who could be doing living donor, related liver transplants, LDLT, in a very, very successful fashion. And his passion is for liver transplantation, and he's a teacher par excellence. He has trained a lot of students who are doing phenomenal work across the country in different centers. And, he has established a hospital for liver transplantation, all for himself, which goes in his name, Dr. Reela Institute. And he's got innumerable publications in international journals. One of the most reputed liver transplant surgeons and hepatologists of the globe, not only India. So he's a pride for the whole nation. And he's fondly called Prof. And so I invite Prof. Reela to deliver this very prestigious oration in honor of my teacher, Dr. N. Madanagopalan, from whom I got the love for gastroenterology. I was his student from 1985 to 87 at Madras Medical College, and the relationship continued until his last breath. So without wasting much of our time, may I invite Professor Reela to deliver his talk.
Thank you. I think I sent a recorded recording of my speech. Are they going to play it now? Good evening. I would like to thank the organizers for giving me the opportunity to talk on this prestigious oration, Professor Madanagopal oration. I'm talking today about the evolving or the changing indications for liver transplant over the years. When you look at the first 7 human liver transplants reported, you'll find that most of them were for advanced malignancies because liver transplant at that time was considered experimental, and the patients who were offered liver transplants were really hopeless patients with advanced malignancy, and all of them died. The only indication which has not changed over the years is actually biliary atresia. Now you've got a huge list of indications for liver transplant in adults. Now, when you look at the changes, the UCLA data of almost 5,000 liver transplant over the years, you will find that the biliary atresia in children, around 40 to 50% of them have remained static over the years, whereas the HCV, which used to be the most common indication for liver transplant, is slowly disappearing, and over a period of time, NASH as an indication is emerging as one of the most common indications for liver transplant. The ULTRA data also shows that in the early 90s or in the mid 80s, even when I started transplantation, cholestatic liver diseases used to be the most common indication for transplant. And they were also easy transplants to do, PVC and PSC with very little portal hypertension. And for some reason, they're all slowly dwindling away in terms of number, even though they persisted at a certain ratio. The hepatitis B was not such a common indication. In the very early stages, the outcome was very poor, but with good treatment for hepatitis B and virological control, the indication, viral hepatitis in yellow indication increased, but I think with treatment for hepatitis C, now that is also slowly disappearing. So what is filling the gap currently, the blue one, is alcoholic liver disease, and to a certain extent NASH are really filling the gap of disappearance of indications over the year. Now, I think the transplant indication has varied over the years for various reasons. One, the disease have been better controlled and they're disappearing like hepatitis C. NASH, the incidence is increasing and therefore the indication is increasing. But indications such as alcoholic liver disease has been the same, but what has changed really our idea and our perception, which is increased indication. Historically, hepatitis B, many of you may not have done transplants or thought about transplants in the era when antivirals were not available. In the very early stages, the recurrence rate was 75%, and the outcome of transplantation, the 5-year survival was less than 50% in the very early stages. And in the early days, when I was meeting the American surgeons, I think most American centers were not doing transplantation for hepatitis B. But it was really with the introduction of immunoglobulin and in the lamivudine era, in combination with immunoglobulin, hepatitis B immunoglobulin, that the outcome of transplantation for hepatitis B improved tremendously. But now really, and this is something that is really a historical disease, fibrosing cholestatic hepatitis. You occasionally see this in hepatitis B patients who have been immunosuppressed or on chemotherapy. I've even seen one patient post-COVID whose been treated with high doses of steroids, but this disease is disappearing. But it wasn't an uncommon problem post-transplant with immunosuppression. You have a rapidly progressive cholestatic fibrosing disease with graft failure very rapidly. I mean, it was a relentless course, and there was nothing we could do for these patients. And even retransplant was contraindicated for these patients. And now with lamivudine and immunoglobulin, the outcome improved. And now actually with your entecavir and tenofovir and combinations of these, actually, the DNAs have become undetectable, and overall the outcome has improved tremendously over the years. Hepatitis B still remains a common indication in the Far East for transplantation, even though in the West it's not that common an indication. Hepatitis C has also, as you all know, hepatologists, the hepatitis C has seen a major change really. In the early phases of liver transplantation, hepatitis C recurrence after transplant was in fact universal. All of them were positive, RNA positive after the transplant. One of the difficulties, I mean, you can see this is the number of transplants done in the United States each year for hepatitis C. The number is increasing. There may be a trend towards declining. This is before the direct-acting antiviral period, is 2011. And the incidence of hepatocellular carcinoma also was increasing with the increasing incidence of hepatitis C virus infection. And one of the problems in the early days was really post-operative management of these patients was not easy. When you got graft dysfunction or severe rejection, and they were also, the C virus was also positive in them. And to distinguish C virus recurrence and really rejection was very difficult, and the treatment are really opposing. If it was HCV recurrence, you need to be reducing immunosuppression, but if it was rejection, you should be increasing immunosuppression. And that complicated the post-operative outlook for these patients. But nevertheless, the outcome of hepatitis C virus transplant was not as bad as recurrence of HBV transplant. Now you all know that the medical treatment for this is greatly improved, and transplantation of hepatitis C, the post-operative complication of recurrence, is not a problem. Even in patients who are not, we're not able to treat pre-operatively, can be successfully treated post-operatively. And you can see this data again from UNOS, 32,000 transplants done, first-time transplants done, of which 15,000 were due to hepatitis C virus. But after the direct-acting antivirals, the outcome of HCV in the DA era is much better than almost 15 to 20%, 15% difference in the survival outcome of these patients. And this is compared to the other patients, non-HCV patients, where the improvement in the survival, at 10 years, you can't see that much compared to the hepatitis C virus patients. So this graph again shows how the number of patients registered and the number of patients transplanted for hepatitis C is slowly coming down, and their space is being taken up by alcohol and NASH as their indications are increasing. But what's interesting is, even though the number of hepatitis C patients is reducing, the incidence of hepatocellular carcinoma in these patients is not, has not been decreasing. I have to say, this is a study up to 2015. I think we need to see what the current situation is. So even though the hepatitis C is treated, I think the incidence of hepatocellular carcinoma has not been reducing in these patients. But maybe over a period of time, that might also happen. So we need to focus now. See, hepatitis C is disappearing, B is static, cholestatic liver disease are reducing, and NASH and alcohol are increasing in number. Now, the NASH, the alcohol story is slightly different from all of this, only because the incidence of alcohol abuse has remained the same and probably increasing, particularly in Eastern Europe. Almost 20% of the adults are abusing alcohol, and the incidence of alcoholic liver disease worldwide is increasing. what is the attitude of the medical professionals, and allocation of organs for these have also all in the past been quite negative, because there was also a perception that the public won't perceive it as well, and if people are seen to be transplanting these donated organs to alcoholics, maybe the donation rate would come down. So and it really, alcoholism is seen as a lifelong disease, that recidivism is common. Its impact is not just medical, it's also social. So there has always been a negative view about transplanting alcoholic liver disease in the past, and that this statistics very clearly demonstrates this. If you look at number of patients with alcohol dependence in the US, it's 14 million, out of which, if you look at patients with decompensated liver disease, about 100,000 per year. And of the 100,000 per year, only 5 to 10% are actually referred for transplant. And of the patients referred for transplant, only a third of them are transplanted. So really, with 100,000 patients, only 1,200 patients are transplanted per year, which is only 1.2% of patients who with decompensated liver disease get transplanted. So the selection criteria for these patients have been very robust, and many patients were not offered transplantation. But that changed. With this French study, which was published in 2011, who claimed that early liver transplantation for severe alcoholic hepatitis was highly successful. The 1997 AASLD guidelines suggested that severe alcoholic hepatitis is a contraindication for transplant. And many viewed it, it was considered a contraindication. The outlook for these patients were not good, and they were active drinkers until the time of admission with severe alcoholic hepatitis, and the incidence of recidivism was thought to be very high. But this French paper clearly showed that these patients have a high mortality. They obviously have around 70 to 75% short-term mortality. And they showed that they could show an improvement of with a 77% survival at 6 months is what they showed. And they very clearly demonstrated that these patients won't be able to show abstinence because they're going to be dead within the 6 months, or 3/4 of the patients are going to be dead. But they used other really criteria to look to see if these patients will get back to drinking or not, which is in the form of really psychosocial assessment, family support, commitment from the family and the patients for lifelong abstinence. So they did not use abstinence as a criteria for recidivism, but they used other methods of assessing whether these patients are going back to alcohol or not. Nevertheless, they demonstrated that the outcome of transplantation for severe alcoholic hepatitis was very good. But they had a very, very stringent criteria or decision-making circles, which included nurses, specialists, hepatologists, surgeons, anesthetists. And any one of them at any circle could actually block them from going off for transplantation. So really, the incidence of relapse after such stringent selection criteria, which did not include abstinence, was very low, really. It was around 10%, 12% was the incidence of alcohol use post-transplant. And after that, many other studies have demonstrated, even though the numbers are not very large, 17, 26, 9, all showing that the outcome can be extremely good with a 6-month survival of close to 90% and 100%, and the alcohol use post-transplant of 22% and 24%. Alcohol use should not be taken as equivalent to abusive alcohol intake as well. So the incidence of graft clot from them may also not be so high. And this American consortium multi-center study also demonstrated the same, a 1-year survival of 94% and a 1-year recidivism of 10%. And a 3-year recidivism of 17%. So it was considered that the 6-month rule is not suited for severe alcoholic hepatitis. Now there is a confusion here, really. And also further studies about public opinion demonstrated that the public are really not so bothered about organs being allocated to alcoholic patients, and therefore many centers had a view that we should abandon the 3-month rule. 6-month rule. I think we should look at the history of how it came about, really. I think when initially the National Institute of Health suggested transplantation, they only said that those with established clinical indications or indicators of fatal outcome and those who are judged likely to abstain from alcohol should be selected for transplantation. But it was actually the insurance company and the healthcare financing administrations which suggested that they should demonstrate a period of abstinence. And in fact, in one case, they were demanding 24 months abstinence, and that court case resulted in really UNOS coming up with a reasonable time period. And in 1997, UNOS came up with a 6 months period. It was not based on any study that 6 months abstinence is good, and they were likely to be not going back to alcohol. So it's really an arbitrary threshold, and this period has never been shown to affect the survival after liver transplantation, and there is a weak association between sobriety and liver transplant outcome. So what all of these studies took on, I mean, anyway, they took this on because these patients anyway cannot show abstinence. Severe alcoholic hepatitis cannot demonstrate abstinence because most of them will be dead at the end of before 6 months. So they looked at really their social situations, family history of alcoholism, whether they failed attempts at rehabilitation. First-time admission was also an important one, that they have not known that they have had liver disease or continue to drink after they have known that they have liver disease. Other substance abuse. So these were all other indicators that these are suitable patients. But the problem with disappearing 6 months abstinent rule is that now people will consider patients, any patient, for transplantation, and you cannot extrapolate the rules for acute alcoholic hepatitis to chronic liver disease, because in chronic liver disease patients, there is a possibility of some recovery when it is possible for them to demonstrate abstinence. You can demonstrate improvement, and if you look at this study, they've shown 6 months is actually a good indication of patients who will truly have irreversible disease. So they chose a group of Child-Pugh C patients, and then requested a 3 months and put a rule of 3 months abstinence for these patients. And 67% of them had improvement in their LFTs. So you could actually some of them to Child-Pugh B, and so not all of them would require a transplant. And I want to also show this study, which is again a French study. This is before the acute alcoholic hepatitis study. 13 transplant centers, and they chose 120 patients. These are all Child-Pugh B patients. Child B patients grouped into two categories, 1 and 2. One was listed for immediate transplant without abstinence, and the other one was a standard care, not offered transplant. So, and these group 2 patients were offered transplant only when they progressed on to group C, otherwise they were not offered transplant. So if you simply look at the outcome of these patients and how many are alive, in the transplanted group, really 29 patients were alive. 29 patients were alive at the end of it, who received 41 received transplants, and again in that group 19 did not receive transplant. So if you look at the whole group, it was 29 patients who completed follow-up, whereas in the non-transplanted group who did not receive transplant, you have 30 patients who are still alive who did not receive transplant. So and then 12 of them survived here. So here 42 patients survived. Here there are 35 patients survived who were in the transplantation group, and 30 plus 2, 42 patients survived who were not in the transplantation group or not in the immediate transplant group, even though some of them received transplantation. So you've really avoided transplantation in a large proportion of patients in the group 2, indicating that not all patients should be offered immediate liver transplant for chronic liver disease. So the rule for alcoholic liver disease, acute alcoholic hepatitis, is very different from the rule for chronic liver disease. And this again shows the immediate listing group and the standard care group. The standard care group is almost 10-15% better than the immediate care group. This analysis very clearly shows that persistence of alcoholic consumption was the risk factor for patients for risk, rather than really improving survival with transplantation for these patients. I'll go on to the next, NASH. NASH, as we know, is increasing as an incident. I won't go into details, and many studies have shown that NASH is really taking over. Now, alcohol and NASH are probably taking over the gap that is left by hepatitis C. Dinesh, our hepatologist, has also shown in our own data that NASH is increasing several fold now as an indication for transplant. The next point I want to make is about how our attitudes have changed towards transplantation for malignancy. In the early phases, we had very strict criteria, the Milan criteria, which many countries are still sticking to this as a criteria for transplant. So the morphometric criteria was the rule in the early 90s, but now those criteria have been expanded, each one coming up with their own criteria, the Chinese, the UCSF criteria, the Seoul criteria, and India also, people have got their own rules about which one to transplant, and most of them are demonstrating similar survival. Now even biological markers are being incorporated into these criteria. What used to be an absolute contraindication for malignancy, macrovascular invasion, is also now proving to be not a contraindication for transplantation. Here you see the Koreans have demonstrated that they can have good survival, 1, 3, and 5 year survival of 63%, 45%, and 45% for patients with macrovascular invasion. And this is in combination with radiotherapy preoperatively. Avisoin from Medanta has also demonstrated that in selected patients with macrovascular invasion, when you do downstaging for these patients, it is possible to get reasonable outcome for transplantation for HCC. Now, what used to be absolute contraindication 30 years ago have all becoming indications now. Unresectable hyalocholangiocarcinoma has now become an indication with very good outcome, and this is a Mayo study which demonstrates 5 year survival of 82%, and there have been many other studies. I have to say, even though these are all facts, the transplantation numbers for cholangiocarcinoma has not increased tremendously. Here, 65% 5 year survival was a combined United States experience of 287. And this is over 10-year period, and I don't think the numbers have increased tremendously for this. Even intrahepatic cholangiocarcinoma has been offered transplantation now. Now, finally, the new thing is liver transplantation for colorectal metastatic disease, unresectable colorectal metastatic disease, with a 3-year disease-free survival of 35%, which doesn't seem good, but in the patients who survive with relapse, they still have a 1, 2, and 4 year survival of 173%. So you can, if you're looking at 5 year survival of 73%, even though they have disease recurrence, it is an acceptable thing. But this is still debatable whether you would be offering transplantation for colorectal disease. And that's why the Oslo people have come up with this rapid concept. The rapid concept is actually an auxiliary liver transplant followed by recipient hepatectomy at a later stage. They have devised this because they felt that we cannot waste an organ for this indication, and therefore in a split liver, they would use part of a liver, a left lateral segment, transplant a left lateral segment, allow, they ligate the right portal vein and allow the right lobe to atrophy, and make the graft increase. This is a concept is very similar to auxiliary liver transplant for acute liver failure. And they feel that this is probably one way to offer transplantation for these patients. The indications for transplant for neuroendocrine metastatic disease has been there for many years. And I feel that there is a huge confusion as to who should be transplanted. We need to be very aware that many patients with neuroendocrine tumor, liver-only metastatic disease will live for 10 years and 15 years with the current options available. So it's very important to understand the natural history of these tumors before offering them transplantation. In fact, transplantation can cut short their life expectancy. I've certainly seen a patient with 10-year neuroendocrine metastatic disease who was transplanted. This was in King's, and within 2 years of transplantation, he had very extensive disease with immunosuppression. Milan Massafero has come up with further criteria for selection of neuroendocrine tumors, but one needs to be cautious about offering this. One thing that I wanted to say is many of you may not think of retransplantation much, but in the early days when I entered transplantation, almost the retransplant rate was almost 15-20% in transplantation. So almost every 5th transplant we were doing were retransplantation, either for graft failure, hepatic artery thrombosis, or recurrent disease, and finally chronic rejection. Chronic rejection was seen in almost 15% of transplants. Here you see the number of retransplants done in the United States is coming down. It's coming down in spite of number of transplants going up. This is a percentage. The number is remaining the same, but the percentage of transplants is coming down. The retransplant rate is less than 5%. And that is predominantly because of tacrolimus-based immunosuppression, which has reduced the incidence of chronic rejection from 15% to almost 2% or 1% now. So retransplantation for rejection has become a rarity these days compared to the olden days. I think the surgical innovation allows multiple retransplantation, and there are many centers who have done the 3rd time transplant, 4th time transplant, 5th time transplant. I was involved in one of the patients who had a 5th transplant in King's College Hospital, but finally died after the 5th transplant also due to recurrent disease. So if one wants to take it, they can keep pushing boundaries. Pediatrics, just one indication which has disappeared is neonatal hemochromatosis. This is not anymore indication for transplant because there are antioxidant cocktail and IVIG which recovers these patients. And the interesting thing is the youngest patient I did a transplant for was a neonatal hemochromatosis. She's 22 years old now, but this is not an indication for liver transplant anymore. And therefore, maybe newborns may not need liver transplant anymore. Just to finish off, I think newer indications are appearing. There is a report of COVID-19 cholangiopathy as an indication for liver transplant. I think we have at least a couple of patients now who are cholestatic for the last 2-3 months post-COVID who may be heading that way. And I finish my talk there, and thank you very much for the opportunity.
Thank you, Professor Rila, for that wonderful deliberation. I think that is befitting Professor Madanagopalan's career and the love for the liver disease and gastroenterology in India. So you have made our nation proud and all of us proud. Thank you.
Thank you. Thank you very much. Thank you.
Since it's an oration, there will not be any discussion or question answer session. So Dr. Virendra Singh, please.
Yeah. Good evening. I'm thankful to the organizers of this conference for giving me this opportunity to chair this session. And this is regarding the SR Naik oration. Can we project the?
Please go on. I'll
graph. Okay. Dr. SR Naik was born in August 1943 in Goa, and he was trained in medical in Mona Azad Medical College, Delhi. In 1971, He was registrar in Irvin Hospital, Delhi. Then in 1973, he joined PGI as a lecturer in tropical medicine. And in 1978 and 79, he went to London for his fellowship in Bartholomew's Hospital. In 1982, again he came back and then established the Department of Gastroenterology at KEM Hospital, Bombay. Then in 1987, he came to SDPGI Lucknow and established the Department of Gastroenterology. He was hepatologist to the core with the excellent clinical, teaching and research skills. He was researching in the area of the hepatitis B and hepatitis E. He investigated one of the largest epidemic of hepatitis E in Kanpur. He had a lot of scientific communication workshops. In the end, he also became chief editor of Indian Journal of Gastroenterology, and he died untimely July 1st, 2002. Dr. Ramesh Roop Rai can now ask the orator, Dr. Ramesh Roop Rai.
Yes. I have the pleasure of introducing Professor SMF Akbar, who graduated in medicine from Bangladesh in 1980, received his PhD in medicine sciences from Japan in 1993. He worked as a full faculty member at Graduate School of Medicine, Aiyam University, Japan from 1996 to 2008. In 2008, he joined Toshiba General Hospital, Tokyo as principal investigator. His pioneer work is in the development of therapeutic vaccine for hepatitis B virus. Presently, he has been conducting studies and clinical trials in the patients with chronic hepatitis B with the therapeutic vaccine to optimize the safe, effective, and the clinical viable regime in this approach for patients with chronic hepatitis B. He has authored more than 100 scientific articles in the peer-reviewed journals. I have the honor of presenting Professor Akbar for SR Nayak oration. Dr. Akbar, please.
Thank you very much. I'm just trying to come with the slides. And so can you hear me and can you see the slides?
Sure, we can see.
Okay, thank you. So thank you very much. My topics will be the innovative therapy for most liver diseases, including liver cancer. And first of all, this is an August night, and really an August night, because just 800 kilometers from my city in the Tokyo, legendary Indian athletes got the gold medal in javelin throw. And in total, there are the 7 medals like this. And this is not something awarded, but he achieved it by his beautiful things. And India is doing very well there. So this August night is really an August thing for all the Indians. And definitely Inasl will take part with this thing. Well, the first I last come from one quote from the APJ Abul Kalam, the late president of India. A dream is not that which you see while sleeping. It is something that does not let you sleep. In fact, the work that I perform over a long period is something like a dream, but it is an evidence-based dream. And it started from to find out the fundamentals of innovative therapy for liver disease, and possibly not only liver disease. Today I'll be talking only about the liver disease, but possibly all pathologies at the cellular level. And the fundamental question was how we maintain daily activities like breathing, synthesis, communication, and all things. I didn't write here. And then why we get sick sometime. And finally, how we manage the state of disease to ease. And to find these queries, at the beginning of the 1980, at the middle of 1980, I just look at the human cellular things. So in a normal human, there are 15 to 37 trillion cells. And length of DNA is 2 meters. And the total length is about 30 to 75 trillion meters, which is equivalent to 30 to 75 billion kilometer. And the important thing is here, there is a dead cell. And every day, 50 to 70 billion cells die, per minute 41 million, and per second, we have passed several seconds after I start my lecture, so 680,000 cells die. And when the cells die, come the debris, carbohydrate, protein, fat, DNA, and many things. And all these things play a vital role in hemostasis, a balance among several, and when its balance is disturbed, then the disease comes. And all these things provided me how this hemostasis maintained, diseases come, and one of the main factor came is the factor that is the immunity. And that is the starting of the development of the immune therapy. The liver disease, this doesn't need an explanation. So you know there are a lot of types of liver disease. These are diverse. Pathology is diverse, etiology is diverse, and complication is also diverse. And the fundamental of the progression of the liver disease, you all know. There is exception, definitely, but with the normal, there is stress. This is stress, maybe different type, maybe from the viral, from the fat, from the other thing. Then it becomes chronic. Here, there may be some acute or chronic or some acute liver failure, then usually cirrhosis and the cancer. So we move like this. Then the proof of concept. So actually, I worked almost all of the liver disease in either human model or in the animal model. But today I'll be discussing about the innovative therapy for 3 liver disease: hepatitis B virus, primary biliary cirrhosis, and liver cancer. About the hepatitis B virus, you all know that there's a lot of drugs starting from the 1990s to 2016. And these drugs are antiviral drugs with some immunomodulatory capacity as usual. And the concept of immune therapy came from this because this virus is non-cytopathic. They cannot kill. They don't have any toxin. Then how they cause inflammation, fibrosis, distortion, lobule structure, alter hemodynamics, liver cancer. And ultimately, it was found that the host immunity, it acts like a double-edged sword. And the manipulation of the immunity have 2 roles. One may be the pathogenic, and other is the protective. And the target of immune therapy in chronic hepatitis B is to minimize the pathogenic immunity and inducing the therapeutic immunity. So people start to try with the polyclonal immunomodulator. So the conclusion is something like this. Also, a lot of things was used. There was no particular follow-up. The mechanism was not studied, and there is no further development. And there is initial optimism, but sustained effect was not found. Then there are a lot of studies starting from 1994 with the HBV antigen specific immune therapy for chronic hepatitis B. And these are some dominant studies which I have been recorded here. And there are also some studies which are done recently in 2018, 19 to 2020 also. And with all these things, it was found that the immune therapy is safe, but it doesn't give the sustained effect. Then in one page, I have compiled the immune therapy, which we did from 1988 to 2006. We studied in transgenic mouse about the concept, design, and optimization. Then 2006 and 7, we tried that immune therapy in the normal volunteer. And 2009, we did the phase 1 to clinical trial. 2012, we started the phase 3 clinical trial. And 2014, the therapy is ongoing, and we are going now to have the almost 10 years follow-up. All this thing was done in Bangladesh. And the study design, so due to the time, I can only say you, there is a 2 group. Each group has 80 patients with chronic hepatitis B, DNA plus, elevated ALT, and they are given a drug, Nasvac, which I have been discussed many times in the Inasl meeting, 10 times nasal, 10 times by injection. And there was the PEG interferon once weekly for 48 weeks. And here is the result. If you see, you can find that before the treatment, there is the DNA level was almost similar. And then at the EOT end of treatment, it low down. And in the Nasvac group, it remained as such, but in the PEG group is increased. And most importantly, after 5 and 6 years follow-up, we found that out of the 78 NASDAQ patients, 2 become cirrhotic, and out of the PEG interferon, out of 80 patients, 10 become cirrhotic. We also studied mechanism, which I have not time to discuss fully, but the core antigen-specific immunity was very important for maintaining these types of thing. And we have done 3 patent applications for this. And now we are going to do one study in which we will stop the nucleoside analog for 1 month and then induce the NASDAQ for 10 times. Well, then in Japan, we had the new clinical trial in which we use the patient receiving nucleoside analog, because in Japan, people have received some sorts of treatment. And this patient has given only by the nasal route. And we found that the surface antigen reduced significantly. And you can find that it is reduced more than 2 log copies. And also about 20% patients develop anti-HBs. So we are now moving in Japan. This has started for 3 years and the study is still going on, and it will be going on for a long time. And we're also trying to register this drug in Japan as well for the patient who have received the nucleoside analog before. Then the concept of the innovative therapy for primary biliary cirrhosis. And this was done by animal model, not in the human. And we use the poly-IC, this is the immune stimulator, and we use different dose. And within 28 weeks, we got a mouse model of something like the primary biliary cirrhosis. So what we found, first, according to the injection, and after the week, the ratio of portal areas with 100% infiltrated cell, and we find it is increasing day by day. We also look for the AMA in poly-IC mice, and we found that there is the specific band in the AMA position, and this was also published, and we found this one. Next, we found this is the internuclear antibody, this is the AMA, and this is the mixed type of antibody. And in the PBC mice, this hepatic parenchyma, we found the involvement of the ductal tissue as well as the infiltration of the cell. So this became a mouse model. And also we found the autoantibody of different types. So just it looks like the PBC-like model. And another important thing we found that in these pathological processes, the antigen present in dendritic cell, actually, which is my main work, was found this blue-like staining with the double stain in immunofluorescence. Then the important thing is about the treatment. So due to the time, I cannot discuss all the things. Only I can say that we produced another type of dendritic cell. This is not immunogenic. Rather, it is a regulatory or it is a negative regulator. And we use, without treatment, the mice has this type of pathology. And after giving treatment with the regulatory dendritic cell, we find a clear-cut liver, and there is the improvement of things. And also the AMA and the inflammation was decreased in this situation. Then concept of innovative therapy in liver cancer. Sorry. So in the liver cancer, so you all know the present regimen is something like this. The problem is there is a recurrence, metastasis, and the location is sometimes very adverse, and the drugs and radiation also have the adverse effects. And we tried a new type of immune therapy, and also we tried this in human. So what is the major point of this concept? The major point was that the ACC antigens would be collected from the cancer nodule in vivo. An immune response will be induced in ACC patients in situ, placing ACC antigen with danger signal for immunity. And after validating the animal model, we'll do the clinical trial. So the thing is this, in case of the cancer, the antigen got some types of changes. So what we are now talking about, the variant of the COVID or SARS-CoV-2, something like this. And for this purpose, the immune responses, which has been initiated, is not enough to have the fight with the cancer. So we thought that we would immunize in vivo. So what do we do? First, we do the animal experiment. We produce a cancer, and we give 2 things. One is the ethanol, it is a danger signal, plus DC means dendritic cell, and one is only dendritic cell. And we found that when you give only dendritic cell, the cancer increased by size. But when you place the ethanol plus dendritic cell, then it was significantly reduced to this group. And this is the first animal experiment was done. And we also found that survival was also increased when we give the ethanol plus dendritic cell compared with the only ethanol. And the most importantly, we also checked the dendritic cell, the double staining with the CD11C and the CD86, and we find that a lot of dendritic cells which are mature, these are the mature dendritic cells, this is red color and this is green, blue color. So this dendritic cell, when mature dendritic cell with both these things was much more in the cancer nodal places. And when all these things was done, then we moved from retrieving antigen and the danger signal in situ. And this one slide will explain almost the whole thing. So the patient has liver cancer. So we need the antigen. And if we take the antigen from outside, that antigen gives the immune response, but that is not so much effective in the cancer because the cancer the antigen undergo mutation, and that antigen does not give the immune response, and the capsule is a hinder for this. So what we did, we just give a probe, and we went up to the cancer, and then we give ethanol to this cancer and disrupt the cancer tissue for 2 days. After 2 days, we just give the dendritic cell over there when the effect of the ethanol was decreased. And then we just follow up the patient. So we got a very special clinical trial permission from Japan, and this study was done in Japan, and we got very special permission from Japan, and we could do in 5 cases. So all these things was permitted only for the patient who has in the terminal stage, and the patient was supposed to stay alive for mostly 1 month or something like this. But out of the 5 patients, 1 patient survived for more than 9 months. So we found that this may be one indication for having a new treatment regimen for the liver cancer. But after that, to have the clinical trial with the chronic hepatitis B, I moved to Tokyo. So I could not continue this study. And this dendritic cell, everything was isolated by me. So I could not continue the study. But again, I have come back to this, my seat, AIME, the original place. And we are going to do this thing here and also in Bangladesh. So if I summarize the whole things, what is the standing? The thing is this, even still now, the dendritic cell or the immune therapy have not become a reality because there is a lot of controversy, a lot of things, and not many people is doing these things because possibly we are the only who have been working on immune therapy for the last 30 years or more. So the thing is this, we think that immune therapy can brought to reality. But what is the need to understand? We must understand the pathogenesis of the animal model, and optimization of the most of the part of the study should be done in the developed country. And initial safety and efficacy study should also be done in the developed countries. And then the bigger study or the long with a lot of people can be done in the developing country. Because most of these studies, I have a very good way to do the study because I was always shifting between Indonesia, Bangladesh, and Japan. So most of this study was initially done in Japan and also optimized in Japan and also tried in human being in Japan. And the safety and the efficacy of these things was confirmed in Japan. Only at that time, I started the clinical trial in Bangladesh. So if we miss one stage, and if there is, because these are very critical, and always there is a safety issue, because we use the core antigen, which is usually considered as a very dangerous antigen for chronic hepatitis B patient, but because the fear of the CTL and everything is done. So I just try to tell a little part of this study. The thing is this, we have used the hepatitis B, a combined antigen with the hepatitis B HBS antigen and core antigen. And this was also produced in Cuba, because when I first got that core antigen is required for immune therapy, neither Japan nor UK nor USA, nobody could produce the full-length core antigen. So at the beginning, I requested the Cuba to prepare the full-length human GMP level of the core antigen, and they prepared it for us, and we could do this experiment. And then brought the core antigen in Japan. And all the animal study in the HBV transgenic mice, which I produced by myself, and that we could do here. And then we did some of the studies in Japan, and we also gave in some patients here, and also the voluntarily we also used in our body, and then we went to Bangladesh. So this is one of the system by which we can progress this study for between the East and East collaboration, between the collaboration of the developed and developing country. So new dream and new thought. And finally, again, this is actually the last slide. So I just like to tell that again, a quote from the former president of India, APJ Abdul Kalam, the dream, dream and dream. So the message is the have courage to think differently, courage to invent, to travel the unexplored path, courage to discover the impossible and to conquer the problems and succeed. We don't know how much we could go, but in Bangladesh, like any other country of the world, we can get antiviral drug. We can have most of the facilities there, but it is not applicable to all the population. So we have to take. So my impression is this: we need to have take some dream, and it is maybe impossible, but it should be evidence-based. For me, at this part, I can say you, I was a late starter because I am a medical doctor. And after 8 years, I went to Japan. And here the atmosphere was diverse. I had a laboratory, but I was not in Japan. Nobody from the outside can be a professor of the clinical department. I have trained about 30 doctors in the PhD course, but that is not enough to do everything. But I think that the next generation will be able to do all these things and acknowledging the reality of the research. The reality of the research is this: we must have the evidence. And the thing, and another thing, the truth is not an ideological issue, and ensuring vision and way to get evidences of all these things. And I'm in contact with the Inasl for quite a long time. But today I didn't discuss about the hepatitis B virus because I have discussed about that several times. So and not only the PBC, also I'm working with the hepatitis C virus and almost all the liver disease, and also extending the boundary of the liver disease. We are going to treat in general all types of cancer because on principle and fundamentally, if I get a antigen and if I get a dendritic cell and can modify and can prepare an animal model, possibly almost all types of disease can be treated theoretically. But optimization requires a long time, because to optimize up to this level, it took about more than 30 years. And maybe, but now the things will move more and more rapidly. And I hope that someday the dream, which seems to be impossible, never to come true, something like a double-edged sword can be done, because we treated 80 patients with NASVAC in Bangladesh, and 80 patients was given pegylated interferon, and all these patients are under strict follow-up. And these NASVAC patients, about 70% patients has the normal ALT and HBV DNA negativity. On the other hand, the PEG interferon patient have the elevated DNA, about the 70% cases. Now I'm deciphering the how we can proceed more, and the study has already got the IRB from Bangladesh to stop the NASVAC, to stop the nucleoside analog. And after 1 month, we'll use the immune therapy with the NASVAC. And by this, we are now going to have something, a finished type of treatment. And the study that we started in Japan in the chronic liver disease, in which the HBs antigen dropped and anti-HBs was developed in about 95% cases, will be another milestone for this type of thing. So in total, this is the things, and really I appreciate all of the Inasl, because I have been there for quite a long time, and I have a lot of friends over there and deeply involved with them. And actually, what the ex-president APJ Abdul Kalam told, we must have a dream. Sometimes it may be impossible dream, but if there is evidence for this dream, we should proceed on with the dream. And finally, I thanks all of you for selecting me for this oration, and thanks all of you to do whatever I can do for the organization, and I'll be with you, and I hope that you will be standing with me also. Thank you very much. Thank you again.
Thank you, Dr. Akbar, for an excellent overview of your research work, which has really given us an idea as to impossible things can be dreamt and they can be brought to the reality. Thank you again for all the members of Inasl for accepting this oration and be the part of Inasl program. Thank you very much.
Thank you. Thank you so much, sir. And thanks once again to the orators, Professor Mohammad Rela and Professor SNF Akbar for delivering this oration. So we move on to very clinical contemporary topics. And before I give the floor to the chairperson, I must convey my gratitude to Dr. Rohit Lumba and Dr. Sengi Lim, who come from extremes of time zone as compared to what we are in India right now. It is very early in the morning for Dr. Rohit Lumba, and it's quite late in the night for Dr. Sengi Lim, but still they decided to be part of this meeting. So I'm really grateful to them. So with this, I give the floor to the chairpersons, Dr. S.K. Tyagi, Dr. Sunil Dadich, and Dr. J.B. Dilavri to start the proceedings.
Thank you.
Dr. Dilavri.
Thank you. I would like to thank Inasl and Dr. Kaushal Madan for asking us to chair this session on contemporary hepatology. It gives me a great pleasure to chair this session with two eminent gastroenterologists such with an interest in hepatology, like Dr. S.K. Tyagi and Dr. Sunil Dadich. The first talk is on non-invasive surrogate markers for NAFLD patients. I must say Inasl could not have done a better job than selecting Dr. Rohit Lumba, who's a professor of medicine and director of NAFLD Research Center in University of California, San Diego. Now I invite Dr. Rohit Lumba to deliver his talk. Dr. Lumba?
Thank you, Dr.
Rohit, you're muted.
Okay, here we go. Can you hear me?
Yeah, now it's okay.
Yeah.
Okay, great. Thank you. Thank you, Dr. Dilavri, and thank you, Dr. Madan, for the invitation. I'm delighted to be here. It's really a pleasure to be with the Inasl community and look forward to the meetings. This is going to be the outline of my talk. I'll cover how do you detect presence of NAFLD, presence of atrus NASH, presence of fibrosis, and predictors of response. Presence of NAFLD, traditional assessment has been liver biopsy, but routinely in clinical medicine, we use ultrasound, the conventional ultrasound. It's not sensitive, so when the liver fat is between 5 to 15%, ultrasound may be negative. CT scan is also not favored because of risk of ionizing radiation and inaccuracy and lack of sensitivity and specificity. The most accurate test would be MRI imaging on spectroscopy that can now be estimated on MR imaging with proton density fat fraction. So for non-invasive assessment, if you really wanted to do that, you could use it. Otherwise, potentially, you could also use control attenuation parameter on FibroScan. But clinically, we are still using ultrasound, and that's reasonable in clinical medicine to see if somebody had fatty liver or not. This is a group of, this is a patient of mine at UCSD where we did two different modalities to identify the amount of fat in the liver. This is useful in epi studies. This is also useful in assessing treatment response in phase 2A and phase 2B trials. And more of that has been coming if you're trying to assess which therapy should be moved forward for histologic assessment. Now, detection of at-risk NASH. First definition of what at-risk NASH might be. So it's patients who have NASH with stage 2 fibrosis or higher. And the reason for that particular entity is because those patients are at significantly higher risk for liver-related morbidity and mortality. And that is why for registrational trial, phase 3 trials, both by FDA as well as by the European Medicines Agency, you need to have stage 2 fibrosis or higher to be included into a phase 3 or a registrational trial for development of a NASH therapeutic. And this comes from these data. So that is the definition of at-risk NASH. So can we identify a patient who needs to be treated without doing a liver biopsy? A lot of work has been done, especially in the last few years. I'm going to move this box so you can actually see. So FAST is a modality that has become available. This is a combination of FibroScan giving you control attenuation parameter. You use a liver stiffness measurement and then the AST, and you can come up with this number. So it is useful, but it has a very low positive predictive value. And that's the biggest issue. If your FAST is 0.67 or higher, that patient probably has at-risk NASH. And if the patient has a FAST of 0.35 or lower, then that patient has a pretty low risk. And so many a time people are doing is you check the FAST first, and then based upon that, patient might get a biopsy to be included into a clinical trial. But in future, we might use this to see which patient should be qualified for a treatment without doing a liver biopsy. But the main issue with FAST is, if you can see here, is a low positive predictive value. As clinician, we want to test when it's positive that we can actually do something directly. Problem with FAST is with this range of positive predictive value, it is not that accurate. So even if a patient has a has a FAST of 0.68, you're not 100% sure, and you want a certainty of a 90% or higher. Therefore, we still need further testing. So we worked on that, and we combined two parameters. If you take FIB4 plus MR elastography and you combine it, we did the study prospectively at UCSD and then followed it up at Japan. This was recently published in Gut. If your MR elastography was 3.3 kilopascal and FIB4 was 1.6, you had a 97% positive predictive value. So I think these could be potentially useful in terms of assessing, let's see if we can put it there, in terms of assessing who has high positive predictive value. And if you achieve these two, then you definitely don't need a liver biopsy because you have a positive predictive value above 90%. There are two consortiums that are currently working on non-invasive biomarkers. One is NIMBLE that I'm part of in the United States, and Litmus, which is in Europe. However, more needs to be done. Now moving on to detection of fibrosis. Traditionally, we use FIB4 that includes age, ALT, AST, and platelet count. We've categorized FIB4 based upon low likelihood of advanced fibrosis, intermediate, and high likelihood. Again, the main issue with FIB4 or NAFLD fibrosis score is they're good for ruling out disease, not high positive predictive value. That's why the intent of developing MAFIB score was to have something with a high positive predictive value. ELF or Enhanced Liver Fibrosis Panel has also been available. We'll discuss some of these data, but this is showing you just data that as stage of fibrosis increases, ELF values go up. And is there a clinically important ELF value that would be important? And this might become available, at least in the United States, within the next year or so. And it's available in Europe. So can you predict a outcome and follow patients longitudinally using ELF and what those cut points might be? So this is a question in a patient with NAFLD and bridging fibrosis. So we have a stage 3 fibrosis patient. You can imagine you have 100 of those. Which of these 10 or 20 are going to progress to cirrhosis in the next 2 years? How do you differentiate that? Who needs to be prioritized to be seeing you versus, maybe a nurse practitioner or a prioritized for treatment. So this will be ELF of 9.8 or higher. And this comes from these data from simtuzumab trial that those with higher ELF had a significantly higher risk of progressing to cirrhosis. This is looking at ELF of 11.3 or higher. If you have a cirrhotic and you line up 100 cirrhotics, can you predict which cirrhotic is going to have decompensation in the next 2 years? And you can use these data. ELF was 11.3 or higher. This cirrhotic would be at higher risk. So again, you can prioritize these for treatment trials as well. What is the optimal strategy for population at-risk management? Well, at least from the United States perspective, FIB4 might be one possibility. This is not perfect, but it can help at the population level. So you could exclude patients who are FIB4 below 1.3 or at least below 1, and then keep people that are 2.67 or higher. These will be high risk. They should be seen by a hepatologist, in my opinion. And then those are intermediate, might get a second test. And this could be ELF, this could be elastography, this could be FibroSpec2, and then elastography could be a FibroScan or a MR elastography. And then if you had MR elastography availability, then these are some of the cut points you might use. 2.55 or below, it's pretty much normal. So these patients could be just followed. There's no need for a biopsy there. If you get to an MRE of 3 or higher, you start looking into that these patients should be followed in our clinic. We talked about the MEFIB score. These patients definitely have stage 2 fibrosis or higher with 90% positive predictive value. These should be prioritized. If you have an MRE of 3.63 or higher, this is high risk for advanced fibrosis, which is stage 3 and stage 4, 93% positive, 93% accuracy for this. Now about FibroScan, I think I just wanted to simplify things. This will be coming out later. We are also trying to develop ASLD practice guidelines within the next year. But if the liver stiffness is below 8, the likelihood of significant fibrosis or any fibrotic disease is low. Some people do 7.5. I think within that range, you could probably prioritize those patients and see them maybe, once a year to once every 2 years. Now, those with the liver stiffness between 8 to 12 kilopascal have fibrotic NAFLD, and it might range depending on their body mass index, but that's where you're looking at patients with stage 1, stage 2, stage 3, and some rarely stage 4 fibrosis may also be there. And then LSM of 12 or higher, that's where you might see more of stage 3 and stage 4, but I have people who have completely normal and no fibrosis and have mild NAFLD with liver stiffness of 12. So I think the main idea is that understanding these cut points is important, with the understanding that FibroScan is not a very accurate test, and it will have an accuracy ranging from about 0.75 to 0.8. And so 25% of the time, you may not be accurate. And just having that understanding is important because you probably want to assess patients more holistically. How about predicting treatment response? If you had a trial or if you were following a patient just with weight loss and other lifestyle intervention, how do you follow that the patient is improving or not? So here are some of the criteria. Serum ALT, if you started with an elevated ALT, then what amount of ALT decline is associated with histologic response? And all of these measures are related to some data that we've looked at. So I just collated everything here. Normalization of ALT would be one, and 17-unit drop in ALT is associated with histologic response. Higher odds. So these are odds in terms of, this is not an absolute, but this gives you that, oh, this patient is improving and this patient is not improving. MRI PDFF, we've done a lot of work. I'm not going to show all that, but just putting a bullet here. If you see a 30% decline in liver fat over 12 to 24 weeks, you have a pretty high likelihood, 5 to 7 times higher odds of histologic response. You see 50% decline, you have 8 to 10 times higher odds of histologic response. There's a new modality called multi-scan or corrected T1 offered by Perspective. So you start seeing 85 millisecond or greater reduction. The patient with NASH with stage 3 fibrosis starts, say, at 900 milliseconds. They drop to 800. That patient has a significant response. Probably if you were to do a biopsy, it'll show improvement. FAST is another thing. This recent paper by Vincent Wong that was presented showing that if you had a 0.2 decline in FAST, it's associated with NASH resolution if you were treated with semaglutide. MRE, based upon some of our study, if you start seeing 15 to 20% reduction, then that's associated with histologic response. What about disease progression? If a patient is progressing, how do you follow that patient? So you could now, when I see a patient, my note includes their alcohol assessment, also includes their FIB4 assessment. And so you can monitor on FIB4. And I think the easiest way to monitor on FIB4 would be changing category. If patient had a FIB4 1.1, comes back to see you 2 years later, now is 1.7. So now this patient has switched categories. I think you should think about, I need to do something about it, and I should probably intervene. This is important if your patient is jumping categories. They were 2 and then went to 2.67. That's a pretty significant jump. I would definitely assess that patient for progression. ELF, again, we discussed these two cut points. You could utilize them also for longitudinal assessment. For FibroScan, there's a recent paper by Petta and colleagues that a 20% increase in FibroScan, especially in those with bridging fibrosis cirrhosis, is associated with disease progression. So I think you could take that. MR elastography, based upon our data, about 15% increase just because it's more precise. And some people still take 20%. So if you just want to remember, on liver stiffness, 20% increase is associated with disease progression. So somebody was a FibroScan of 8, now at 10, that patient needs assessment, they've progressed. So in summary, non-invasive assessment is taking the center stage in risk stratification. MAFib and FAST may be used to identify at-risk NASH, and then MRI PDFF response of 30% is nicely associated with both 2-point improvement in NAFLD activity score and NASH resolution, and FibroScan and MRE may also be used to follow patients for progression. Thank you.
Thank you. Thank you, Dr. Luma. It was an excellent talk. Very simple and straightforward to do non-invasive test. And I think we'll have questions at the end of both the speakers. So thank you for this. Now I invite Dr. Sunil Dadich to introduce the next speaker. Dr. Dadich, please.
Thank you very much, sir. It's my pleasure to invite Dr. Seng G. Lim, who is the Director of Hepatology at Division of Gastroenterology and Hepatology, National University Health System, Singapore. He graduated in 1980 from Monash Medical School, completed his research MD at Royal Free Hospital. He is a member of editorial board for various journals, including Liver International, Journal of Wild Hepatology, Hepatology International, Alimentary Pharmacology and Therapeutics. He is currently a chairman of Singapore Hepatology Conference and Science of HPV.
Thank you very much for Thank you very much for inviting me, and let me share my screen. Can you hear me?
Yes. Yes.
Right. First of all, I'd like to thank President Rao, President-elect Professor Singh, and Secretary General Professor Madan, and of course the organizing committee for Inasl for inviting me to give this talk. It's a great honor for me to speak at your meeting, even though it's a little bit late in Singapore. The topic of my speech is achieving functional cure in hepatitis B. These are my disclosures. So what is functional cure in hepatitis B? And a number of meetings have examined this, and it's been defined as sustained S antigen loss or seroconversion 24 weeks of therapy with undetectable HBV DNA. This can be achieved currently. Hello, can you hear me?
Sunil, you need to unmute your mic. Sunil?
And it can be achieved with existing therapy, and ideally to be achieved in 30% in phase 3 clinical studies. Absolute or a complete cure is absence of cccDNA and absence of integrated HBV. This seems to be unlikely to be achieved in the foreseeable future. So, how common is the benefit of S antigen loss going to lead to clinical outcomes? This is a meta-analysis that looked at the important clinical events that occurred following S antigen seroclearance. And you can see here, liver decompensation reduced by 72%, HCC reduced by 70%, liver transplant or death was reduced by 78%, and the first clinical event was reduced by almost 70%. So this marker, the surrogate marker of S antigen loss, leads to significant clinical benefits for all our patients, and it should be the stretch goal for hepatitis B treatment. So how good are current treatments in achieving functional cure? Well, we did a meta-analysis a number of years ago that looked at this the combination of interferon and nucleoside analogs versus nucleoside alone. And we found that the combination therapy had a higher rate of S antigen loss, 6.5% versus 0.5% for nucleoside analogs. Interferon versus nucleosides, again, 3.6 versus 0.27. But there's no difference between the combination and interferon therapy on its own. So these were all very high quality studies, 43 high quality randomized controlled trials with low risk of bias. So I think you can see here that the achievement of S antigen loss, even with the best forms of treatment, is only in the single digits, which means that this is unlikely to be achieved with current therapy. Nucleoside analog long-term therapy leads to S antigen loss in very few patients. Modeling predicts that 36 to 39 years of nuke treatments is required to achieve S antigen loss, although a few patients do have a substantial reduction in S antigen over time, but this is less than 1% of the treated cohort. And these are long-term follow-up studies from randomized trials, and in this case, from tenofovir treatment. There's been a lot of interest in stopping S antigen with using quantitative S antigen as a threshold. And this is a systematic review of Asian patients who were E antigen negative. And we find that the threshold of less than 100 IU per mil leads to a 21 to 58% S antigen loss, with clinical relapse occurring in less than 30% of patients. So this could be a good threshold to stop nucleoside analogs, but I would hesitate to say that not many patients achieve this threshold over the treatment periods we're talking about. So another issue is, after S antigen loss, can HBV return? So this is a meta-analysis looking at hepatitis B reactivation after patients were treated with rituximab. And these were patients who had resolved hepatitis B, the S antigen negative, but core antibody positive. And using rituximab, which blocks B cell function, leads to hepatitis B reactivation in about 15% of S antigen negative patients, suggesting that in these patients, it's more likely that cccDNA is silenced rather than eradicated. But if we give heavier immunosuppression, for instance, in liver transplant, where we knock out both B cells and T cells, what is the reactivation rate? The de novo HPV post-liver transplant is as high as 72%, suggesting that if we have intense immunosuppression, the reactivation rate is much higher, indicating again that most of these patients with S antigen loss do not have elimination of cccDNA, but just silencing of cccDNA. Consequently, new therapies are needed to achieve functional cure. And in this schematic diagram and of the life cycle of hepatitis B, you can see that it's quite a complex profile of different targets that are being used to treat hepatitis B. And I'll simplify them as three broad strategies. One is to inhibit viral replication on the left-hand panel here. And these include nucleoside analogs, capsid assembly modulators, and entry inhibitors. Lowering viral antigen, such as E antigen and S antigen, using RNA interference or nucleic acid polymers, and boosting immune response through a variety of strategies, such as innate immunity modulators and immune enhancers, and of course, therapeutic vaccines. First of all, let us examine the hepatitis B life cycle to understand how these mechanisms work. And I broadly simplified the life cycle hepatitis B into two overlapping pathways. The replicative pathway starts with pregenomic RNA, which then gets inserted into capsids, and these immature particles then form mature viral particles with conversion to HBV DNA, and eventually this gets secreted as active viral particles. However, another pathway is actively secreting antigens such as E antigen and S antigen, which are not affected by nucleoside analogs, because nucleoside analogs and capsid inhibitors affect the replicative pathway. But if we want to cure hepatitis B, we need to attack the S antigen pathway. So the markers of the replicative pathway is HBV DNA and HBV RNA, while the marker of the secretory pathway is S antigen production. So let's look at inhibiting viral replication. And I've already shown you the data on nucleoside analogs to show you that it has limited effect on S antigen production. And when we look at this, I've mentioned to you there are three strategies: inhibit viral entry, inhibit viral replication, and inhibit capsid production. So let me deal with capsid assembly modulators. This is a new class of agents which looks extremely promising. They can be divided into class 1 and class 2, and you can see that within each of these classes, there are multiple agents either in preclinical or clinical trials. The main difference is that class 2 leads to empty capsids, but the capsids are intact, while class 1 leads to aberrant core protein aggregates. So there's a breakup of the capsid itself into core protein aggregates. Now, it is disputed whether class 1 or class 2 actually is better in terms of efficacy. So far, I don't think anyone has demonstrated any clinical difference between the two groups. I'm just showing you one of many capsid inhibitors that are in clinical trials. This is the assembly product, and we can see here that in this diagram, I will highlight the panel on the extreme right in red, showing that there's a very nice reduction of HBV DNA and HBV RNA, shown here in blue and green, but in red is the S antigen level. And you can see that there's only a relatively mild reduction in the S antigen level with capsid inhibitors. Very much what I told you, that the capsid inhibitors affect the replicative pathway and do not have much effect on the secretory pathway. When we look at entry inhibitors, which is Mercledex, and this Mercledex attacks or blocks the hepatitis B receptor, which was discovered a few years ago and is now in clinical trials. And one of the early clinical trials using Mercledex and HDV co-infection showed that at 2 milligrams of Mercledex given over 48 weeks, there was really very little impact on the S antigen levels. You can see it's very flat, and even on follow-up. So what about the strategy of lowering viral antigen burden? Well, there are two classes of agents here, the RNA interference and blocking S antigen release. The RNA interference consists of two main strategies, ASOs or antisense oligonucleotides and small interfering RNAs or siRNAs, and they work by slightly different mechanisms. ASOs are delivered as a single strand and finds its target as alone in the liver, while siRNAs need to go through a RISC complex where it binds to its target there, and then it gets cleaved. You can also use liver targeting with GalNAc, and this has been used in some of these agents, either ASOs or small interfering RNAs. So there you can see here on the left-hand panel that there's quite a few antisense oligos in clinical trials, as well as siRNAs also in clinical trials. So let's see how they behave in the clinic. So I think the first thing to say is that they target all HPV transcripts, and they may be 1 trigger, 2 triggers, or 3 triggers, depending on the specific product in mind. And this inhibits both replication and attacks all HPV antigens and is pan-genotypic in its effect. The good news about capsid inhibitors that is relatively safe. The bad news is that there is some resistance already shown in some of these agents. And you can see here using this product from Arbutus, at different doses, you're getting a very nice reduction in the quantitative S antigen level. There didn't seem to be a dose-related effect here, and the effect was approximately 1 log. Now, this is an ASO from GSK, ISIS 505358. And you can see here on the right-hand panel that 6 injections were given over a period of 4 weeks. And the reduction in HPV DNA seemed to be far higher in patients on nucleoside analogs compared to those who were treatment naive, 2.5 log versus 1.5 log. The reductions in HPV in S antigen levels were associated with hepatitis D flares in some patients, but 4 of these 16 patients who were treated actually had S antigen levels falling below the limit of quantifications, and 2 patients had prolonged S loss. So out of 16 patients, which is quite impressive for a phase 1b study. The other class of agent is a nucleic acid polymer, NAP. I'm sure you've heard about this. NAPs block the production of S antigen secretion. It's not exactly clear how they do that, but the effect seems to be quite profound. And in this early study using REP2055 as a monotherapy agent, no nucleoside analogs of PEG interferon, you can see that some of these patients had profound reductions in S antigen levels and HPV DNA. 25% of patients, or 2 out of the 8 patients treated in this study, had long-term sustained responses. Finally, boosting immune responses. And there are a number of categories of agents. Here, I broadly categorize them as innate immune stimulators and adaptive immune stimulators here. But we should also remember that innate immunity in HPV relies on the interferon pathway to be active. So all these innate immune modulators rely on interferon. So it is pretty much an interferon type of agent. We're looking at GS9688 here, which is a TLR8 agonist. And in this phase 2 study, we can see here that the 2 cohorts were treated E positive, E negative, with 2 doses of the TLR8 agonist, 1.5 milligrams and the 3 milligrams. And I look at the lower right panel here at the week 48 results, shows that significant reduction in S antigen levels in both dose levels, although the bigger reduction seems to be at the 1.5 milligram rather than 3 milligram. 5% of patients, or 2 patients out of 39, had S antigen loss. However, the overall reduction in quantitative S antigen was less than 1 log. And 1 of the 2 patients who had lost S antigen only had a 0.25 log reduction. So we wait further evaluation of this interesting agent, but certainly we can demonstrate here that the TLR8 agonists do have some effect on reduction of S antigen levels. Most of you may be familiar with the use of PD-1 inhibition to stimulate T-cell immunity, and nivolumab has been approved for solid organ tumors as a PD-1 inhibitor. And in this study, looking at nivolumab versus GS4774, which is a therapeutic T-cell vaccine, you can see that the nivolumab monotherapy arm had reductions in S antigen levels in 3 patients, and 1 patient actually had S antigen loss. So in principle, certainly we can be certain that checkpoint inhibitors have an impact to stimulate T-cell responses and to achieve S antigen clearance. Therapeutic vaccines, of course, is a very interesting subject. I think Dr. Akbar has spoken extensively about it. I will not go into details. There are many strategies to use HPV therapeutic vaccines. One of this is listed here as a prime boost strategy. But of course, it all depends on the type of antigens and the adjuvants used and the strategy. However, the problem is overcoming immune tolerance to HPV due to huge S antigen load. You can already, I find it, of course, troubling to understand how we can break tolerance by giving S antigen to patients who already have a large amount of S antigen on board. We have done a meta-analysis looking at therapeutic vaccines, and we really have found no impact of therapeutic vaccines in terms of e-antigen seroconversion and S antigen loss, either versus placebo or versus standard of care. So which combination therapies have been successful? Because I mentioned primarily monotherapies before, and I think I want to bring back to Mercledex. Mercledex with interferon here in HDV co-infection showed that as monotherapy agents of PEG interferon and Mercledex, not much of an effect. But when you look at the combination, there's a substantial reduction in S antigen levels, and approximately 26.7% of patients had S antigen seroclearance. However, the drawback, you still need 48 weeks of PEG interferon. Nucleic acid polymers in combination showed in this trial here, combined with interferon tenofovir, the REP, the nucleic acid polymer, showed dramatic reductions in S antigen levels when it was introduced, shown here in these green line charts, and a functional cure was achieved in 40%. But again, you need interferon, nucleoside analogs, and of course, the nucleic acid polymers. Finally, you can use triple therapy in combination with nucleoside analogs, the CAMs and RNAi, and this study from Janssen shows that there's a very nice progressive reduction in quantitative S antigen when you give them 3 in combination. So in principle, I think this is a strategy that most pharmaceutical companies are examining looking forward. So there's definitely more than one path to functional cure. You can use potent combination therapy that I've shown you, the J&J triple combination, Mercledex, tenofovir, and interferon, NAPs, tenofovir, interferon, or you could possibly you can try a strategy of reducing S antigen levels and then stimulating with T cell function, but this as a potential therapeutic strategy needs to be proven in clinical trials. So to finish up, HPV treatment strategies to achieve functional cure require blocking viremia, antigen load, and either silencing or removing cccDNA and stimulating innate immunity, humoral responses, and T cell responses. So to conclude, I would like to say that functional cure is now an achievable endpoint associated with improved clinical outcomes, and is most likely associated with cccDNA silencing rather than eradication. Agents that have little effect on quantitative action in early studies cannot be completely discounted. Example, in Mercledex may still have efficacy in combination. Combination is the most promising, but sequential therapy may be another therapeutic option. And quite likely there are multiple pathways to achieve functional cure, but strategies currently that have been successful in achieving cure in more than 20% of patients have relied on PEG interferon. With that, I'd like to thank you for your attention. I'd like to thank all these pharmaceutical companies and Ed Gain for allowing me to use their slides. And I'd like to announce that the Science of Hepatitis B Cure virtual conference will be on October 11th to 15th. And if you're interested in this subject, we'll have the world experts talking about how to achieve functional cure. Please visit the website. And thank you very much for your attention. I'll be happy to take questions.
Thank you, Professor Lim. Jung, I think we, though we've run out of time, not having any questions is almost contrary to the whole ethos of holding a conference. So I would ask you, Jung, if you have any questions. Otherwise,
I got one question to
just one,
Dr.
yes,
Lumba.
Okay.
And that is, you see, MR facilities are not available in most of the countries. And also people don't like to do liver biopsies. So what we left with the non-invasive markers like the FIB4 and NAFLD fibrosis score, would that not be enough? Maybe adding ELF to that? Would that help? How much does it help in actually avoiding MR and liver biopsy?
Yeah, I think it is very helpful because especially at the population level, you could probably save a lot of money by just using risk stratification. The only problem with FIB4 assessment is patients may have other things going on, and those may not be assessed, especially if they're younger. So if a 40-year-old patient comes in, their FIB4 is always going to be below 1.3 most of the time, and they may have other liver diseases going on, and people may not even investigate. That's the only thing, but totally I agree. There's no need to be doing, from my perspective, if your FIB4 is below 1.6, you could save a lot of money. The lower the FIB4, less likelihood of significant disease. The cut point that we find to be safe, based upon our research, is below 1. There is definitely no need for fibrosis risk stratification. Those patients could be seen 3 years later. So if FIB4 is below 1, you could basically make sure that they don't have anything else going on. They can come back in 3 years.
Thank you.
Professor Lim, what is your experience in prolonged, if you have prolonged suppression of the virus in Hep B on conventional treatment which we are given, say if the patient is suppressed viral suppression for several years, could one actually, because most patients in India are very keen to get off medications, and they spontaneously stop medicine after say about 3 or 4 years out of sheer the new term that has come is getting exhausted of all this. And so what is your experience? How many of them relapse, and how many of them actually continue to have viral suppression?
Well, I think I've shown you that systematic review. So I find that quantitative S antigen is quite useful. There is some emerging data that if you have those ability to measure correlated antigen and HBV RNA, RNA is not commercially available now, but correlated antigen is available from Japan. If those are positive, then there's a high risk of relapse if you stop treatment. But quantitative S antigen is still probably a very useful marker. I don't know whether it's commercially available in India. It's available in most. I think it's just been approved in the USA. So this tool actually, if you hit 100, there's a good possibility that you're going to have a lower risk of relapse and a higher risk of S antigen loss. Now we are doing a clinical trial at the minute to confirm whether the 100 cutoff actually is as good as they say. And even in this class of agent, we've enrolled 87 patients. We've had 3 severe flares. One of them had to be rescued with plasma exchange and steroids, and he became jaundiced, and he was a non-cirrhotic. So it's a risky business. So I think patients who stop it on their own, and we've seen quite a few of those. I've had 3 patients the last 6 months who had very bad flares. One of them died, and 2 of them had to be rescued from liver transplant. So it is quite a dangerous thing for patients to stop on their own. They need to understand that stopping nucleoside analog is something that needs to be monitored very closely, particularly if they're E antigen positive. If they're E antigen positive, you don't even bother to stop them. They're at the highest risk.
Yes, Professor Dilawri, one more question?
No. I'm just saying that there's a long way to go to achieve functional cure for hepatitis.
Which is why we need all these new agents.
Thank you.
We still have one more very exciting part of this session at 8 o'clock, and that is a panel discussion on ascites. I briefly saw the moderator's face. There it is. Sanjeev, who is the principal, Dr. Sanjeev Sehgal, who is the principal director and head of liver transplant hepatology at Max Hospital, Saket. He is perhaps one of the first liver transplant hepatologists in practice, which itself shows how much we've progressed from liver transplant being an occasional event in a chronic liver disease to being enough to actually choose to have a liver transplant hepatologist as eminent as Dr. Sehgal. As I will leave it to him, and I think his sheer persona, his knowledge, his charm is definitely required to handle a panelist as variant as as diverse as Dr. Pandey, Dr. Sharma, Professor Devinder Singh, and Setu Babu. So I hand it over to you to introduce your panel and to take forward and try to keep them all moderated at the topic, and we have a very nice discussion, I'm sure.
Thank you so much, Dr. Tyagi, for the wonderful introduction. We are going to discuss on a topic which we have been, like dealing with for the last 2-3 decades, right from my MBBS days, ascites. So it's really something exciting to know what we can offer today on this topic of ascites and cirrhosis, which is unique. And a very galaxy of very eminent panelists we have got today. A very experienced Professor Virender Singh. We have Professor Setu Babu, Professor Mithun Sharma, and Professor Gaurav Pandey. I think we will start sharing my screen and. So now the topic is vast and we have a very limited time. So I think what I would say that request the panelists to answer their questions briefly and to the point, so that we can cover as much as possible. And of course, ascites is something it's not possible to really cover it in a big way, but I think some important clinical issues which are relevant, that I would try to emphasize. And of course, our panelists would be the one who would be making their point. So to introduce this case, I will be presenting this 59-year-old male who's still being seen by us, alcoholic, cirrhosis 2019, repeated LVPs, had melena, gave APCs done multiple times, had SBP, but advised transplant. For some reasons, he cannot really go for liver transplantation. Developed massive hydrothorax recently, had an ICD insertion, had an obstructed hernia, had emergency laparotomy, multiple problems, is on maintenance, twice weekly albumin infusion, then once weekly, and so on. So his lab parameters, usual anemic patient with a very low albumin, renal function generally, slightly on the higher side, 1.38, viral negative, MELD 13, CTP 9. So this was a very shrunken liver, which we can see, typical cirrhotic patient, no HCC though, and had a white out lung on the right side, which was compromising him. So emphasis would be today on the first issue, which is refractory ascites. I'll have a couple of points, and I'll request my panelists to chip in and make their comments. How do we define in this current era? Is there something new? What are the tips and tricks in management? Is anything again different? Professor Virender Singh and Gaurav can take up that. Then cautions before we label a patient with refractory ascites, a checklist, very important. Dr. Setu Babu to be taking up that, and any role of vasoactive drugs. Again, also I've just put these names to make my own self comfortable, so that I know there's a question and somebody's going to answer it. But any of you can answer, whoever feels comfortable. There is no really restriction. All of you are free to chip in and answer. Keep your answers brief, a minute or two, not long, so that we are able to understand it. So right from this, we go to the first one. Professor Singh, how would you define refractory ascites?
Refractory ascites is ascites which is not controlled easily with the measures like the salt restriction of less than 90 millimoles and the maximum diuretic use, that is 160 and 400, or there are the appearance of the side effects. The refractory ascites can be called maybe a diuretic resistant ascites, or if they develop the side effects like the hyponatremia or hyperkalemia or maybe encephalopathy or the renal failure, then this is another problem in these patients. So we'll have to be very careful, and slowly we increase the diuretic every 3 days. If there is no weight loss, usually we take 0.8 kg in 4 days, and every 3rd day we increase the diuretic dose. And diuretic intractable ascites, most of the time we see the diuretic intractable ascites. The diuretic resistant ascites is not so common because we are not able to reach the maximum dose of diuretic. And this is what, as per the ESL guideline, the treatment duration should be at least a week. And then the lack of response, 0.8 kg over 4 days. Early ascites recurrence, if it recurs within 4 weeks. And diuretic-induced complications, as I told, hepatic encephalopathy, renal impairment, hyponatremia, or maybe the hyperkalemia. So we'll have to be very careful. And if the refractory ascites develops, one of the very common problem in these patients is the development of SBP. And then most of the time, these patients may be either they are not compliant to the salt restriction, or they are taking the beta blockers, or they may be taking the NSAIDs or the ACE inhibitors. These are the usual problems. So we'll have to take a proper history, and then we should be managing patients with the refractory ascites. And the common management of refractory ascites is the large volume paracentesis.
We'll come to that, Professor Singh. We'll come to that. We'll come to that, Professor Singh, shortly. So with that definition, now I'm really sometimes concerned that we may label something as refractory, but we have to be very careful. So, Dr. Setu, like in your practice, before you label a patient as refractory ascites, is there anything you want to ensure that you're not missing, that it is genuinely refractory and that is what it is?
I think the standard teaching is there are two types of patients who, they quickly respond to your standard diuretic. I agree with Professor Virender Singh that the definition of high dose Lasix and high dose aldactone probably has changed. I would like to draw the attention of the midodrine era, which has come up, which increases the renal blood flow. So that's a very specific action, unlike the other diuretics. I think there is a change. I thought we will say, are we really seeing refractory ascites as a refractory ascites? What happens is the tendency that large volume paracentesis has changed to probably a mode like TIPS. I know I'm prematurely making that comment. I thought there is not really refractory ascites as a big clinical challenge to us if we judiciously use the diuretic. And I thought maybe the Professor Virender Singh would also comment whether the midodrine has changed the era and we are not having the true checklist to call refractory as refractory. We also have a standard teaching as ascites which is not responding. You look at complications like portal vein thrombosis, which is added up, or a tumor which has developed in these people, and the tumor related thrombus in the portal vein is a third problem. I think we all look at these added areas for a refractory ascites. So ascites not responding to standard of care would simply mean refractory for us, and we will look out in other options, and we are cutting short these refractory ascites with an intervention which is in favor of patient. I thought so. No more refractory ascites is a problem for us till we do some kind of intervention. I don't know whether I'm looking at tangentially.
I think very rightly you have made a point, a very good point you have made, and I think your point that we have to ensure there's no portal vein thrombosis, no SCC and all, and it's really genuinely refractory, there's no cardiac function and so on. So I think I completely agree with you that a true refractory...
May I comment?
Sure, Dr. Singh. Sure.
Regarding the use of midodrine, it is not well established. We should not use midodrine left and right, and without midodrine, we should call it a refractory ascites.
Right.
And then the LVP is okay. And these patients, if we see a lot of patients with the refractory ascites, and these are true refractory ascites, we increase the dose of diuretic, they either develop the hyponatremia or hyperkalemia, or they come with the SBP. So we see a lot of patients with refractory ascites.
Right. So Gaurav, if you have to really delineate the steps in you have a refractory ascites patient, and what are the steps you would like to take, stepwise approach to that. So Dr. Gaurav, would you like to make a comment on that?
Dr. Gaurav probably could not connect.
Can I make a Dr. Virender Singh? I want to know, learn from you, what is the experience of midodrine? Because we thought it seems to have changed the outcome. I don't know. This is a training, because earlier what happened, it was a very expensive drug. We had a hesitancy in using, but when we looked at the actions of the drug and they started slightly using it, maybe I'm biased, but I want your opinion on that.
See, I'm using Midodrine for last maybe since 2005. I started 2004. I started using Midodrine, and I used it, and this is quite useful. But only thing is that we have to prove it. There are studies in which they have questioned this, the use of Midodrine. The study by Guinness et al., and they have questioned it. So unless already the double-blind RCT is going on in our place, and maybe we'll get the results, final results, maybe in a year's time.
Great.
So there are not many studies on the use of Midodrine in pure refractory ascites.
Fine.
So our study was there, but that was a very small study. Now we are doing a larger study and that double-blind RCT.
Right. Great. So Professor Mithun Sharma, are you there with us?
Hello.
Yeah,
May
Dr. Mithun.
No, I'm Gaurav here, sir. May I come in? Or?
Yeah, hi Gaurav. Yeah, we were missing you earlier.
Sorry, sir. Actually, I was muted. So just looking at this case, sir, just one or two comments. As you
I wanted you to just
yes,
basic steps in management. You are a refractory ascites, so how would you just steps in management? What would be your approach? Clinical approach. Just a clinical
steps
approach.
The basic steps in management, as described in literature, is large volume parasynthesis, TIPS and alpha pump and liver transplant. But just to add to this, sir, so predominantly just discussing this case we had presented is predominantly has portal hypertension problems with a MELD of 13.
Yeah.
Now it's predominantly a portal hypertension problem that will decrease effective arterial blood volume, reduce the MAP, maybe increase the RARI and have decreased IVC filling and decreased urinary sodium. Now, so the the issue is not so bad liver functions as decreased effective arterial blood volume compromising the effective renal output, GFR and urinary sodium. Now, this requires therapies to increase the effective arterial blood volume with albumin and vasoconstrictors. Now, the other issue is, all of us would agree that all the patients with refractory ascites may not have equal HVPG. Somebody may have HVPG in late teens, somebody may have in early 20s, somebody may have in late 20s. So the amount of vasoconstrictors required may vary. At some place, oral vasoconstrictors may help. At other places, you may require IV vasoconstrictors. Now, IV vasoconstrictors have been only studied in HRS, but is there the time to push the goalpost and look at the amount of portal hypertension, decreased effective arterial blood volume to consider this therapy so as to ultimately achieve the effective arterial blood volume, increase the urine output.
Right.
Patients like this who have good liver functions may benefit.
Right. So that's pretty useful, and I think we are going to understand about this as we discuss further. So we just started a little bit of discussion on Midodrine, and I think both Setu Babu and Dr. Brenda Singh have hinted on that. Dr. Mithun, I would like to know from you what would be your comment on the role of vasopressors, especially Midodrine in refractory ascites.
Right. So as we know that the data is very less, but what I feel is that the patients who benefit the most with Midodrine are the ones who have a lower mean arterial pressure. And what we feel is that whether Midodrine can improve the tolerability of the diuretics, because majority of the time, because of the low BP or hypotension, we are not able to escalate, forget the renal function for the time being. So actually a meta-analysis was done recently from our center where it was shown that possibly Midodrine could improve the tolerability of diuretics. So we are starting a study on this where we are adding this up with another arm of less electron, whether we can push up the diuretic dose or the requirement would come down. So we definitely use Midodrine as of now for patients with low MAP. IV vasoconstrictors, I don't know because it will be a temporary solution. We can reverse it, but it's going to come back. So something oral would definitely be better.
Yeah. So Dr. Virender Singh, you have been doing a lot of work on this right from beginning. So when you are looking at a patient, like Mithun said, you have low MAP to start with. So do you have some parameters to select out patients for use of midodrine in refractory ascites?
Yeah, we looked at this also in our earlier study. We tried to find out what is the level of the MAP, but we could not correlate it. But my practice, if apart from the trial which I am doing, if I have to use the midodrine, I will use it especially in patients who have a MAP of less than 82. And they are the one who are benefited most. And because most of these patients will have some amount of the SBP, and if SBP is there, there is a MAP is low. So first you will have to do a diagnostic tab. And then after that, if there is no SBP, definitely, then you put them on, maybe use the proper diuretic. And then if they are not tolerating, you can take help of midodrine. And midodrine should be started maybe 5 mg 3 times a day. And then you can go up to 7.5 mg or maybe 10 mg 3 times a day.
Right. So I think we have, we do agree that it has its own place, but I think more data and evidence is needed. Because this patient had hydrothorax, and I think this is a nightmare for hepatologists. And Dr. Gaurav, what do you do when you got a white out lung in a cirrhotic?
So the same thing, actually, we use vasoconstrictors, increase the albumin and give a very high dose of diuretic. The fluid has to be mobilized, portal hypertension has to be reduced, intravascular volume has to be increased. So putting ICD is the common practice that all of us do, but thankfully for the last 8-9 years that I've been at SGPGI, we have been managing them with the low albumin with terlipressin and diuretics. But short of that, putting a ICD drain and then sending the patient for a liver transplant evaluation and workup is the best possible outcome that can be thought in this scenario.
So, any comment on role of TIPS in a patient with hydrothorax?
Yeah, TIPS is another option that can be considered, but the results of TIPS are slightly inferior to refractory ascites. In absence of other options, TIPS definitely can be considered. But thankfully, if the management that we have been using, we are pretty happy with that. But if it can be used as a bridge, basically, before transplant is considered.
I think that's a very right.
Can I make a comment here?
Sure.
Yeah, actually, we did MRI reconstruction of the diaphragm in these people and found small to medium to large defects in the diaphragm, which is actually the cause of hepatic hydrothorax. It disrupts. I think the right word is it disrupts. And then there is a rent through which it happens. So if you could handle the ascites very carefully, I think even the hydrothorax tends to come down. I want comment on experience with people like Virender.
Yeah, the management of hydrothorax is no different than the refractory ascites. So you control the ascites, or for that matter, in these patients, there may be a very little ascites, but the whole chest is full of the fluid. So the whole ascites has gone into the lungs. So that is why the treatment remains the same as the refractory ascites. And you can give the vasopressors, maybe oral vasopressors or diuretics, and then the long-term albumin therapy also in these patients. So these are all measures as similar to that of refractory.
Right. So I think that's a good concept message that for all of us, management is the same. But yes, the worst thing which happens is you put a tube and you cannot take it out. So ICD is something I'm really worried. I would not like to do that.
The other issue is vasopressors. No, many times the dose required in hepatic hydrothorax is higher than patients with ascites per se. And as Virender Singh sir has said, the ascites many a times is mild to moderate. It's not tense.
Yeah, right. So, okay, next, again, very important issue. This patient in the hospitalized situation went to a sodium of 116 actually, right? He was on waiting to transplant for some donor issues and all. He was not able to get a transplant. Again, this is a very long problem, but I think very briefly, if somebody would like to, like Professor Mithun would like to answer, hyponatremia, which patients you would like to treat, and very briefly, which agent would you like to use?
So normally we treat only those who are symptomatic hyponatremic. And if a patient is on diuretic and I have to send him in as an outpatient, I tell him to monitor his electrolytes. And my cutoff in our center is around 125 is the sodium cutoff that we take. coming to the
what is symptomatic hyponatremia? What are symptoms?
Symptomatic means if this hyponatremia is causing some amount of lethargy, weakness, which is not amounting to an hepatic encephalopathy. Because it will soon precipitate an encephalopathy. So somebody coming with 115 or 106, definitely we will try to treat the hyponatremia. So if it is a very significantly low hyponatremia, we still have to give 3% sodium chloride, but majority of the time, if it's a mild hyponatremia like 120, we try fluid restriction for a day or two and see if the sodium improves or not.
Professor Singh, would you like to use tolvaptan in your patients?
No. See, these patients with the hyponatremia, you will have to find out the cause. Majority time, this is an overdose of the diuretic, or this patient may be having SBP. So you'll have to be very clear whether it is because the SBP or because the overdose of the diuretic. In that case, you have to stop that. And then, see, hyponatremia, if it is majority patients with the cirrhosis will have hyponatremia, because the cutoff there we take, if we take it 135, less than 135, roughly 50% will have. If we take it maybe 130, then maybe 20-30% will have the hyponatremia. And unless we are planning a liver transplant, that too in emergency, we can just forego it unless it is symptomatic. So treat, because this is a dilutional hyponatremia. So you use the drugs. First of all, you reduce the salt intake, not that give the 33% hypertonic saline. No, that is going to worsen the ascites. See, this is a major problem. Unless this patient is for the liver transplant, you may like to correct it within maybe 48 hours or the 72 hours. In that case, you can use it. But the first and foremost is the reduce the water intake.
Yes.
Limit it to 1 liter. And then after that, if there is no SBP and the MAP is reasonable, maybe more than 82, then you can use the albumin, use the midodrine or the any other vasopressor you can use, and after that you use the tolvaptan. If you are using tolvaptan in these patients with a low MAP, renal injury will develop. So if there is the MAP is good, or you can build it up by midodrine and albumin, and then after that you can give tolvaptan. But you have to be very, very careful in giving tolvaptan, because this is a double-edged sword. You have to correct it very slowly, and you can give it maybe 15 mg BD or maybe 15 mg OD, and then you will see the urine output has gone significantly high. I've used it in maybe the urine output from 500 ml or 1 liter goes to 2.5, 3 liters. It is like as if we have opened a tap. See, you will get a very good result with the tolvaptan, but you have to be very, very careful. It should not be more than 8 in 12 hours or 24 hours.
Yeah, your point is well taken, and I, in fact, honestly, I tell you that I've honestly stopped using it actually, and even in transplant patients who are waiting list, most of the times we are able to get away with fluid restriction, very very meticulous fluid restriction, salt restriction, and so on, and even 3% saline also. Very hesitant in using, but those are exceptions which is mostly it's like fluid restriction and salt and albumin, which really would help. Very very basic issue again, but I think this is a practice based thing. Maybe Dr. Setu Babu would, with his vast experience, can tell us, in current era, has your SBP prophylaxis thought changed? Do you use anything?
I think what happened is, with the advent of rifaximin, it became, standard of care. Earlier, the first papers were talking on norfloxacin as prophylaxis, ciprofloxacin as prophylaxis. But with the advent of rifaximin, I'm of the opinion, Professor Virender Singh will comment, the incidence of SBP in a closely monitored cirrhotic has come down significantly. It did not become a major problem for us actually. I don't know. Maybe I was giving credit to, the rifaximin which we have been using the frequent albumin and improvement of the nutrition. I think SBP and nutrition have a close link. If you can increase the protein calorie malnutrition in these people and improve the muscle, actually the standard teaching is don't take fat, but we all agree that we allow them to take some fat to improve the calories. I think with this, I am of the opinion that the SBP is coming down significantly in the real-time practice. Professor Virender and Mithun would comment because they also see large number. SBP is not a great problem for us. Maybe thanks to rifaximin, thanks to the kind of management we are doing.
I mean, we do face it. Yeah.
All of us are giving rifaximin. That is not a problem. But how many of us are doing a diagnostic tab? That is a problem. See, you have to do a diagnostic tab and send it carefully. And then you will see patient is coming with a mild pain and ascites is not responding. This is SBP. And if you look at the map is low, this is SBP. So, and they also have the renal dysfunction associated with it. So unless you do the diagnostic tab, you will not be able to say that this is SBP. We see it very frequently.
Right.
In our busy OPD, when patient comes with the ascites, difficult to control, I always ask them to get a diagnostic tab. And this is SBP which creates the problem.
You go by the polymorphs or you go by the culture positivity?
No, culture is not so positive.
Right.
We go by polymorphs, the count, cell count on.
Right. Yeah, Dr. Sidhu, like we face this problem in transplant patients very frequently. You know, they come with ascites. So it's sometimes a big problem. You know, just a day before transplant, you do a TAP diagnostic, and it comes out to be 600, 700 cells, and by definition, it is SBP. So you're really stuck up at that stage.
And not only that, we have done a diagnostic tab today, and then that is not suggestive of SBP. But patient is not improving. And after third day, again, I ask my resident to do the diagnostic tab, and there is a SBP clear cut.
I think Professor Dilavari wants to make a comment. Sir, your comment. I think you want to make a comment, sir.
You could see him. I couldn't see him.
I saw his hand on the side.
Oh, you recognized him. Oh, yeah. Okay. Let him come. I think he's a great person to be.
I think, sir, you're muted. Professor Dilavari, you're muted. He had been my thesis guide. I can see him anywhere, actually.
Oh, he's guide.
So I'm enjoying this session very much indeed. On practical issues, particularly hydrothorax, you said tips would be indicated, but I think there was a balanced view on that. That is, treat them as ascites and don't bother with hydrothorax as such. And also, Webturn was a very balanced approach from Dr. Virender Singh, and also midodrine, which is not being accepted worldwide, but I think we should be very careful. We need a bigger trial, a longer trial, and a large number trial to find out whether this midodrine is effective or not. But I'm enjoying this session. Don't let me interrupt her.
Okay.
Go ahead.
So in the last segment, with a limited couple of minutes left, I just wanted, the experts open, anybody, judicious albumin use in cirrhotics. I think this is a big problem. Everybody has his own way of using it, and maybe I think anybody. Gaurav, would you like to briefly?
I think my name is first. Let me.
Dr. Sethu, okay. Yeah. My apologies, Dr. Sethu.
No. We were quite excited when the landmark paper was published that you give 40 grams of albumin, twice a week, weekly, daily. All those things came up actually. Subsequently, there is a recent publication which says all that is not exciting. Albumin alone, albumin with the diuretics, albumin with midodrine. I think, but still, we go by some kind of, you have seen cirrhotics with 1.6 grams of albumin. You have seen cirrhotics with ascites with 3.2 grams of albumin. I think our tendency is to give albumin as frequently as possible. I will quote unquote, cost being one of the factors, and we do not know the safety of albumin. After all, these are all extracted from placentas and tissues like that. We don't have true, very good synthetic albumin, and everything is imported from different sources. But still, I have only a blanket statement. We tend to use guided or unguided and say the patient is ascitic, patient has got low albumin, is edema. For example, edema is more important than ascites. There are cirrhotics who have no edema and large ascites. Cirrhotics with edema would be one of the indicator pedal edema would be an indicator to give them good doses of albumin.
But Dr. Setu, if I may interrupt, pedal edema can be because of venous insufficiency also.
I agree. But then you take those people, you just you see those people who got an edema tend to have a low albumin. This is roughly correlated. There are other ways. They have a venous thrombosis, venous stasis, and all age. I agree with you. But I think the serum albumin would still, low albumin, with tendency to give albumin. That's all I know.
So may I just interrupt here?
Yes, sir.
The issue is not about albumin per se. We have done trials with 40 mg weekly. We have done trials with 20 mg weekly. We had looked at various combinations. The issue is, does the kidney get adequate blood supply to filter? That is the key, renal arterial blood flow. To get the RARI, even if albumin is 3.2, HVPG might be very high, there will be significant splanchnic vasodilatation.
Okay.
You require a combination of albumin plus vasoconstrictors. If the patient is in hospital getting albumin infusion, you have to think of intravenous vasoconstrictors. The main aim should be to get adequate blood flow to the kidney. If portal hypertension is high, maybe vasoconstrictors might be required to be increased. If albumin is 1.6, maybe portal hypertension is not too bad and albumin might be required to be increased. There is no absolute single correct dose of albumin or vasoconstrictors for each cirrhotic. It's a combination of albumin and portal hypertension that requires to be corrected with monitoring of renal arterial blood flow. RARI ultrasound guided is a simple marker. It's not very simple, but a day-to-day clinical marker that helps us at PGI to get the urine output going.
Right. Thank you, Gaurav.
Sanjeev,
I think you, yeah.
Sanjeev, can I make a comment?
We just finished our scheduled time, so organizers might switch
I'll
off.
just
Okay.
make the comment regarding clearing some of the doubts of Dr. Setu Babu. Albumin, we use it left and right, and it is quite safe. There is hardly any problem with the albumin. Only thing is that we have to be very slow in infusing albumin. Otherwise, these patients will end up in LVF. And the ANSWER trial has cleared so many things in the albumin. The long-term albumin is useful. You can use it 40 gram in a week. And regarding the midodrine and the albumin, the SOLAS trial, the MATCH trial, has already shown that it is, although the number was only 9 at the end of 1.5 years, and in that, they have shown that it is not useful. Albumin in that study was not given in the adequate doses. They gave 40 gram every 2 weeks. So in the ANSWER trial, initially they gave the human albumin in it's a large number of patients, 431 patients.
So I'm afraid, sir, we have to wind up now, sir. The time's up actually, and I totally agree with your point, Dr. Singh, that very right. It's used in the right way. It is going to be very useful. Yes. Although cost is an issue in our country, and that is in most of the therapies which we use. Nevertheless, I mean, this is a thing which we all know. So I think we have come to the a short conclusion of about what we discussed today with a very limitation of time, and I think a couple of points which Professor Dilavari actually beautifully summarized when I was asking him. So I think a very last minute comment from a chairperson, and then we wind up this session.
No, I think we enjoyed the session thoroughly. I've learned myself some practical points as well, and I think time has come to to close this session. And thank you, Sanjeev, for conducting it so well and raising the important issues in the management of ascites. Thank you.
Thank you, sir. And my thanks to all the panelists and all the audience. Thank you very much.
Thank you so much.
Thank you. Dr. Sanjeev, can you stop sharing the screen?
Yeah, I will. And thanks to Kaushal for the opportunity.
Yes. So before we end, I think I have 2 or 3 announcements to make. One is, I think today's session was I agree the number of logins were less this time, but I blame it on India winning a gold medal in track and field event. It happened around 5:40 or 6, and I think I don't blame everyone if they wanted to be glued to their television sets. So the attendance was exactly half of what it was yesterday, and I blame it on that. That was one. Second, all the participants can download their certificate of attendance from the main platform. If they go to, there'll be a button, there'll be a link. If they click on their link, they will get a certificate in their name of certificate of attendance. Second, there were two, there was one plenary session today and there was another poster award session today, the results of which would be declared in the valedictory function towards the end of the conference around 9:15 tomorrow evening. So please make sure that you are present there. And tomorrow, once again, we have very interesting sessions, again, very tightly packed. So last day, but it is going to be the most interesting. So in Hall A, we will have the Young Investigator session. There will be a very cheeky debate, cheeky because the presenters are supposed to present it within 8 minutes each. And then there'll be a case-based panel discussion on ACLF, an entire session on complications of cirrhosis, hepatology, how it is practiced today and how it will be practiced in future. That will be in Hall B, and an entire session on pediatric hepatology again in Hall B. And finally, in Hall C, there will be a clinic session called Clinics in Hepatology, where Dr. Thuluvat will be presenting very interesting clinical cases and throwing questions to our very learned faculty and how they would their clinical practice. And for hardcore researcher, a research methodology workshop, followed by a session on recently published Inasl guidelines. So that would be tomorrow. So I urge you all to be present there. Thank you once again and good night, and enjoy the gold medal which the India has
Keep
won.
praying that we win some more medal tomorrow as well.
Thank you. Fine.
Thank you so
Thank
much.
you very
Thank
much.
you.
Thank you.
Thank
Mr.
you.
Nand.
Thank you, everybody. Good night. Good night.
Bye-bye.